Good afternoon, everyone. We are convening the Joint Committee on Consumer Protection and Commerce and the Committee on Commerce and Consumer Protection. It is Wednesday, April 8th, 2026, right about 2 p.m. in conference room 329. The purpose of this info briefing is to discuss and get more information on the potential partnership between Hawaii Pacific Health, or HPH, and Hawaii Medical Service Association, or HMSA, including its potential impact on healthcare services across the state. Honestly, there's been a lot said about this potential partnership, the effect on healthcare, the effect on doctors, kind of the effect on our entire community. I myself and many of our members have been receiving questions and concerns from the community about this potential partnership. And in our previous info briefing, we were told that not a lot of the details had been worked out yet, pending the filing to the Department of Justice. Now that the Department of Justice filing has been made for the potential partnership, we're hoping that more information will be available not only to this committee, but to share with the rest of the state and with the citizens concerned about this potential partnership. Jared, did you have anything to add?
No, thank you to friends from the House for reconvening this briefing, and for everyone who's joining us today for making themselves available to have this discussion.
All right, so normally I have a very strict 2-minute time limit, but I'm going to make a nice exception for you guys, and you guys are going to get more than that. Try not to go too crazy, though. I think we're going to try to keep it within 5 or 10 minutes. My staff should have been in contact with each of you, allocating time depending on how much we thought you needed. But if this timer goes rainbow flashy, that means it is celebrating the end of your speech. So just try to wrap it up. We'll try to be a little more lenient, but I do want to leave time for questions for members as well. We'll start off with HMSA, but did you and HPH want to do a joint talk, or did you want to do it individually?
No, I think we can speak individually.
Okay, so HMSA, please.
Chair Keoho Kalole and Chair Matayoshi, members of the committee, thank you for the opportunity to speak to you today. Typically, as you know, my style is usually to speak without notes, but multiple questions were given to us in advance, and to ensure that I cover most of them, if you don't mind, I'm going to read from my notes so that I cover everything. I did want to start by grounding us in something I think we can all agree on, is that healthcare in Hawaii is under a lot of strain today. The status quo has not produced a result that is worthy of our family, friends, and neighbors. Costs continue to rise. Families, for employers, for the community. Our population is getting older and sicker. We are increasingly dependent on federal funding, which under the current Trump administration is less predictable, is a nice way to put it. At the same time, access to care, especially primary care and specialty care, is getting harder and harder for people across the state. Underneath all of that, there's a fundamental problem, and that is that healthcare is fragmented. The reason why it's fragmented is that care is not coordinated, information is not shared, and too often we are reacting to illness rather than preventing it. That means that people don't get the right care at the right time. They don't get it in the right place necessarily. They certainly don't get it at the right cost. And when they finally do, it's at the most serious and expensive part of the disease process. This is not sustainable for the people of Hawaii, for sure, or for the future of healthcare in Hawaii. And that's why we're proposing One Health Hawaii. So at its core, One Health Hawaii is about bringing coverage and care together, to bring it so that we can coordinate care, so that we can improve outcomes, we can lower long-term costs. It's about moving from a system that reacts to illness to moving one that works to keep people healthy, preventing illness in the first place, or certainly preventing the progression of it to the more serious and expensive parts of it. So now with that preamble, I want to say I recognize that there has been a lot of discussion, frankly some confusion about what this all means. So I want to take a few minutes to explain first 3 important concepts in plain terms, because I think they're central to understanding what we're trying to do. The first is care coordination. So let me give you a simple example of what care coordination means. Let's take a condition like diabetes, which is very common in Hawaii. Today, one part of the system, HMSA, knows who has diabetes. Another part of the system, Hawaii Pacific Health, Queens, Castle, many of the others, they take care of the complications when they happen, but they're not well connected. Patients may see multiple doctors, but information is not always shared between them if they go to different places and different systems, and no one person or one entity is fully accountable for managing the patient's health over time. As a result, people don't get the support that they need early until they show up into the emergency room, or worse, to the inpatient with serious complications like kidney failure, vision loss, limb loss. Care coordination means changing that. It means not waiting till it's devastating to patients and extremely expensive to the system, but catching everything early and managing it early. It means sharing information, aligning care teams, focusing on managing the condition early, helping people with their diet, medications, lifestyle, so they stay healthier and avoid the complications altogether. That leads to better lives for patients and lower costs for the system. The second concept I wanted to talk to you about is what you commonly hear referred to as value-based care. Today, most healthcare operates on what we call a fee-for-service model. In simple terms, providers are paid for each service they deliver. So the more procedures, the more visits, the more tests, the more payment. What this means is that the system pays for treating illness after it occurs, after it worsens. So that's where health systems have to make their investments to take care of it. What we're trying to do is move to a system where the investments can be made further upstream, toward a system that rewards better outcomes, where providers are supported and incentivized to keep people healthy and not just treat them when they get sicker. So instead of spending when it happens that someone is at their worst, we invest earlier so that we can prevent progression of the disease to that point in the first place. It's a proactive approach rather than a reactive approach. The third concept I want to talk to you about is something that has been discussed quite a bit in all of the sessions that we have, and that's called a payer mix. And you've heard concerns that this model could somehow shift healthier, better paying patients to one system and leave others with a disproportionate burden of more complex, lower paying patients. So let me be very clear. That is not the intent of One Health Hawaii, nor would it be allowed to happen. This model depends on maintaining access, protecting safety net services, whichever health system is providing it, because they all provide safety net health systems in various ways, and ensuring patients can continue to see the doctors and hospitals they choose. Also, logistically, it can't happen. In Hawaii, there is no capacity in one place to shift anything to anywhere. We lack access everywhere. Wait times are too long everywhere. There's no way to move people from one place to another. And finally, in the healthcare space, we operate in the most highly regulated environment in the country almost. The insurance commissioner, the attorney general, other regulators are specifically in statute tasked with ensuring that healthcare remains accessible, affordable, and fair. The statutes that this esteemed legislature has put into effect protects the people and the systems from going down a path like that, that would be unfair. So the current system is under strain, and without change, those pressures will only increase. So I would argue that danger to safety net procedures and provider mix and all of that are far more concerning in the current status quo than they would be in an integrated model. So now I want to briefly address a few questions that I know have been top of mind as were provided to me by members of this committee. First, what is the One Health Hawaii structure specifically? So it is a nonprofit parent organization that will help align strategy and coordination between the two existing organizations. It doesn't replace them. So operational decisions like coverage, provider networks, care delivery remain at HMSA and Hawaii Pacific Health as they do today. Second question was asked about workforce. What has HMSA done about workforce recently? It is true that we have made some workforce adjustments recently, which are not uncommon, by the way, in an organization our size, and we've done it many times in the past. But I want to be very clear, those decisions are not related to One Health Hawaii. They are business decisions driven by the headwinds that we're facing in healthcare today, the tremendous losses we had to revise our care models to correctly address the kind of issues we're addressing today. Third, network adequacy and access. Patients will continue to have choice. Providers will continue to practice independently, and maintaining broad access to care across the state is a core requirement of this model. Ensuring network adequacy is a health plan function. So that will remain the responsibility of HMSA. It's actually in statute. And all government lines of business are required by federal regulations, and most large employer group businesses have network adequacy in their contracts with HMSA. So we have specific network adequacy requirements everywhere within the health plan, and it will be the health plan's responsibility to maintain that. Finally, let me address another broader question that I've heard, that this somehow creates more bureaucracy. In reality, One Health Hawaii is about simplifying, not adding bureaucracy. The result of consolidating shared services will result in fewer, net negative, number of executives, one chief information officer, one general counsel, one chief people officer, etc. And those people are coming from our organizations today, so it's net negative. Yes, initially there'll be two CEOs because each of us bring vastly different expertise to the equation. I have experience running a health plan, Ray has experience running a health system. It would be bad for the state for us to do things we're not familiar with. So this co-CEO model is a logical, prudent, and common way for integrations to be structured initially. But ultimately, make no mistake, the goal of One Health Hawaii would be to have a single CEO. And yes, initially, there will be a new position running HMSA because I'm going up to One Health, but that person already works for us. President and Chief Operating Officer of HMSA will run HMSA. So we're not adding any net new people to this whole structure. By bringing alignment today where there's fragmentation, we can reduce duplication, improve coordination, and make a system that works better for our patients. And there will be a net negative number of executives. So let me close with this. We know there are a lot of questions, and there should be because this is a big change, but it is really an important change. It's a very important proposal. It deserves the careful review that it's getting, and we welcome that. But there is a robust regulatory process that is looking at all components of this, both at the state level and at the federal level, and that is ongoing today. That will examine this proposal in detail. The process exists today, put in place by this legislature to protect the people of Hawaii, and we respect it fully, and we are participating and cooperating fully. Our commitment is simple. We will be transparent, we'll answer your questions, and we will work toward a healthcare system that delivers better care, better outcomes, and more sustainable future for our state. Thank you, and I look forward to your questions.
Thank you. HPH.
Chairs, members of the committee, thanks so much for having us. Thanks for everybody who joined. I will keep mine a little brief because I think Dr. Mugisha did a nice job of outlining the why we're pursuing One Health Hawaii. A few things that I would highlight is, one, we agree that the current system is unsustainable. And while I understand that there's anxiety, there's lots of questions anytime you recommend a change of this magnitude into a system, and specifically a system that affects so many people across our state, it's going to create anxiety and questions and concerns. But I would share, as someone who's been working in this industry for almost all of my adult life and serving at the CEO level for nearly 25 years here in Hawaii, that we should be much more concerned about what the current trajectory means for the people of Hawaii. What it means is that we are going to continue to have access issues across our state if we don't do something to disrupt the current system. We're going to continue to see double-digit increases in the cost of healthcare for the people of Hawaii. We're going to see the system of care continue to be burdened by administration if we don't do something to disrupt the current system. And frankly, I think we're going to break the backs of the providers who have spent their whole life training with the intent of caring for the people of Hawaii. And so I am a strong advocate for the fact that we need to do something positively to disrupt the healthcare system, which is unsustainable at this time. And so I just want to use the remainder of my time to maybe talk in a little bit more detail about a few things we talked about before. There's been a lot of questions and concerns raised about the $2 billion projected savings. And so I want to remind the committee and others in the room where those savings come from. Okay, first they come through administrative savings, consolidation of corporate resources, just as Dr. Mugiishi talked about. Taking every place where there's one corporate service and consolidating them into one. That isn't a test. That's a model that I personally know works. It's a model that I've been a party to as we created Hawaii Pacific Health. On December 21st of 2001, we created Hawaii Pacific Health on the backs of 3 legacy healthcare systems. At that time, the administrative costs as a percent of revenue were 46% of our total revenue. Today, they're 26.5%. We have brought real value to the people of Hawaii through the creation of Hawaii Pacific Health, and there is no reason that such value can't be garnered through One Health Hawaii. When you think about it over on the scale of the organizations, remember you're talking about a $6.5 to $7 billion combined enterprise. You're talking about hundreds of millions of dollars of savings over the course of the next decade. The second area where that $2 billion is extracted from is through relieving administrative burden. We've already talked about it before, so I won't be too repetitive. We're talking about dual case management, sometimes triple case management. We're talking about prior authorizations. And a lot has been talked about why can't we just do that now? If you'll recall, I talked about the element of trust. There are only so many things that you can do contractually. And while there may be able to be some agreements between a provider organization and a payer organization like HMSA, don't forget we also have the patient who isn't necessarily a party to that same contract. And so that administrative structure has to be weaved together through a system of care that is designed to steward over the health of the population versus just only in itself caring for the sick. And that requires a systematic overhaul of the way healthcare is delivered and funded. And again, we've been a witness and a party to being able to watch that be successful. At Hawaii Pacific Health, we started taking what we would consider global risks through a contract with HMSA. While we still do prior authorizations and double and sometimes triple case management, we've been able to enter into a globally capitated, which means we get paid on a per member per month basis versus just getting paid based on volumes of activity. The rate of increase of the cost of healthcare to the average employer across the state of Hawaii over the last several years has been 12.7%. The rate of increase in the medical cost trend for the population that we serve, that we've taken risk for within Hawaii Pacific Health, is 3.7% over the last 4 years, or the initial 4 years of that contract. And we believe when we create the capacity to enable other providers to come into the fold and bolt on to the work that we're doing and commit to sharing risk on the basis of the population, that can become a reality for all of the members of HMSA, and frankly be transported to the folks even in the government payer systems through creating structural change, allowing that to happen. Okay, so that's the second area. The third area are the things we've already talked about. It's aligning incentives to make sure we have the ability to provide the right care at the right place at the right time. So if you're someone who has an upper respiratory disease or a cough and a cold, if you will, and you go to the emergency room, it's going to cost you on average somewhere around $1,100. If you go to an urgent care center, it's going to cost you about $270. If you go to your primary care doctor, it's going to cost you in the ballpark of $70 to $75. And the difference in those costs are applied and impacting the cost of care for the entire community. And so when you add those things up and aligning the clinical integration components that Dr. Mugiishi talked to, which also allows us to draw down additional funding through aligning those incentives, suddenly $2 billion becomes very realistic over a 10-year horizon. And when you add that $2 billion into the fold, it's almost like found money. It's money that is already being spent, but we get to repurpose on improving the system of care and repurpose it to creating a healthier Hawaii. And so the 3 buckets that we believe primarily that those will go into are first and foremost, bending the cost curve. So moving away from that 12.7 annualized increase for our employers, which by the way also creates tremendous wage pressure for our employers. And as you all know, when you think about affordability in our state of Hawaii, it's not just cost of living. It's also that our wages have not kept up with other communities across the country. And so we free up some of that when we create capacity by moving that to a more normalized CPI rate like 3.7%, which we've experienced. The truth is, we don't even have to have, when that savings is created, you don't even have to have everybody performing at that level. You can reserve against that savings to be able to allow the insurance rates or the insurance premiums for the entire population to be lowered to that 3.7% or more close to CPI. So that's the first bucket of which that savings will be repurposed into. The second is investing in the healthcare ecosystem, investing in those areas where we have vulnerable populations, where there are healthcare deserts, where they don't have the services they need. It's about putting specialists on our neighbor islands, where right now, because they don't exist, that those folks are getting on airplanes and coming to Oahu for care. We all know that's not as high quality care, it's more expensive care, and it creates disruptions to families and communities across our state. And so it allows us to invest in those areas, again, repurposing that $2 billion worth of savings. Now, you could ask, why doesn't HMSA or HPH do that now? You have to have the value creation of that $2 billion to be able to invest in those areas. So investing upstream in the ecosystem. And I gave other examples about that the last time we met. And the third area, which is the area where I believe is the most impactful in the long view of creating healthier communities, it's investing in those upstream activities, the social determinants of health, the social economic factors that truly affect healthier communities. Things like early childhood development, K-12 education, affordable housing, workforce development, food securities, those areas. It's newfound money that is created through creating structural change that allows us to spend existing dollars more effectively, more efficiently. And the intent is that all boats will float higher. I'm speaking as the CEO of HPH today. When I put on the hat for One Health Hawaii, I become provider agnostic. There is no reason to suggest that it would be efficient or effective for Hawaii Pacific Health as a provider to begin placing those resources on Maui, on the Big Island, when we already have Maui Health with established structures to be able to do that. The question is, how is One Health Hawaii able to repurpose that $2 billion of savings to help them to provide those services in those communities? It makes no sense for us to start putting physicians where we don't have a physician base today on the Big Island. It makes sense for us to work with HST in Queens when they build the new hospital in Kona. It makes perfect sense for us to work with them with the dollars that are repurposed of that $2 billion from One Health Hawaii. And so when we look at this, one of the things you haven't heard us talk about, I don't think you've ever heard me say it, and I don't think you've ever heard Dr. Mugishi say it, is how or why this is good for Hawaii Pacific Health or HMSA. What you've heard us talk about is why this is good for the people of Hawaii and why it's good for a more sustainable healthcare system. The other thing I guess I would just end with is I've gotten a lot of questions again about the $2 billion and what if we don't achieve it? Look, I'll own the fact that achieving that's an act of execution. We have to be able to execute it consistent with what we've committed to in our regulatory filings, what we're required to do by statute, and what's in the best interest of the people of Hawaii. But let's just consider if somehow we only achieved a fraction of it, which I will tell you, I have great confidence based on the models I've seen that we'll be able to achieve the $2+ billion. But if we only achieve a fraction of it, say a quarter of it, say we only save $500 million and we reinvest that. That's $500 million reinvested for the people of Hawaii versus a trajectory that is a negative direction. And so I consider this, while it represents a seismic change from the current system of care. I will tell you, as someone who's been thinking about this for the better part of the last 15 years, it is intended to be a seismic change. And while I know it makes people uncomfortable, if I'm being completely honest, I'm unapologetic about it. Because I think this is the shot in the arm that we need to really begin changing the way healthcare is delivered and funded to create better access, more affordable care, less burdened by administration, that allows all boats to float higher. And so I look forward to your questions, and thank you for allowing me to speak.
Okay, thank you. Members, I'd like to have everyone present first and then we can open it up for questions. So Queens is next.
Thank you. I'm Jason Chang. I'm the CEO of the Queens Health Systems. Thank you, chairs, for allowing us a second opportunity to share our position. I want to recognize a few friends that I've brought with us who share similar positions as I do. And so first one is Kevin Holu, president of the Hawaii Teamsters Local 996. Rosalie Agassiou, president of HNA OPEIU Local 50. We've had discussions, and I just want to share that we have people behind us as we talk about our opposition to One Health Hawaii who feel very similarly. And so we've heard the story, many times. I think I can recite it now myself.
Go ahead, please. Sorry.
But we're still extremely concerned, and it's not about what's being said. It's about those things that are just not being said, the things that are real intended or unintended consequences. So as you hear the aspirational things that One Health Hawaii wants to achieve, those are great. Those are aspirational. They're the same things that we're trying to achieve in our own respective spaces today through relationships with HMSA and relationships with other payers and relationships with each other as peers. The issue is that we don't need the merger to do those things. And so the structure that you hear presented doesn't allow you to actually accomplish anything. So why does the merger need to happen? The more we hear about the vertical integration, the more I become very centered on the fact that this is not just vertical integration or partnership, this is a merger. So you think about the executive making decisions, having like one legal counsel or one CEO at the top making decisions for the two respective organizations, to me is a conflict of interest. And we think about legal counsel. I rely on my legal counsel to provide proprietary information and guidance for a set of information. And to have it on both sides, that to me is again a conflict of interest. And so structurally, as we think about what One Health Hawaii represents, it's a monopoly. It's putting two organizations that have a tremendous amount of power, have a tremendous amount of information about each other's, all of the providers in this room, our contracts, the kind of outcomes that we have, which can be used to weaponize the relationships between us and HMSA. It's a huge concern. I think that the monopoly side, really is true. HMSA represents over half of the population of Hawaii. So absolutely, within the infrastructure of One Health Hawaii, you cannot take all of the patients within that structure at HPH. But what you can do is make your population lower cost, lower utilization. So your cost to deliver care allows you to keep your rate of inflation low, 3%. And everyone else that has to take care of the behavioral health, the trauma, the vulnerable patients, those costs will go based on the quality of the patients that we're seeing. And in many cases, we don't have an opportunity to tell patients, don't walk into our emergency department. There's laws called EMTALA that mandate that when patients walk in the door, we can't ask what insurance you have, we can't ask about your conditions, we have to render the care, and we do. We're very proud that we render the highest level of care in the nation. I think the anti-competitive, so this creates an anti-competitive environment where the patient's care is not at the center. So if you think about what we're trying to do globally in Hawaii is we need to take the sickest patients, the ones that are utilizing care because they don't have affluence, they live in rural communities, they don't have the ability to access the providers that they need to keep them care, they don't have the health literacy. And so those are the patients that are causing the greatest amount of cost, unnecessary costs in the health system. And it takes not just one organization, it takes every organization, every primary care provider, every geriatrician, every pediatrician, all the psychiatrists, all the resources that are out in communities to band together and agree that there's a common way that we can take care of a patient, a population better. And that only happens if we have partnerships that create more trust. I think you heard reference that there's only so much trust that can be built unless you vertically integrate. It doesn't say a lot for those that are not part of that vertical integration. So I think what you're going to see is that costs will be driven up. Not just if this One Health Hawaii doesn't succeed, but I think you're going to see that if we can't take care of that population better, which is exactly what's happening here locally and nationally, costs are inflating because the average age of patients are growing, that the health conditions, especially the chronic disease, are being less managed, that costs go up. And if the costs go up, especially in the Medicare and the Medicaid population, what happens is cost shifting, that they're going to raise the rates, the premiums on the commercial patients. So that's why organizations like the Teamsters and HNA, who have thousands of members who have healthcare costs that could be passed on to them, and others in the community that have commercial insurance. And those are the things that we have to protect against. So we also thought that HMSA, as we think about One Health Hawaii and this integration, HMSA technically has a vested interest to see that HPH is successful. You think about the financial flow, one CFO, does that not disadvantage everybody else that's outside of this vertical integration? So again, we're concerned that does it create an unnecessary advantage and a reason why you would create an uncompetitive playing field? We fully believe that there is. And so those are some of the things that are not being said, need to be talked about. There need to be some assurances, and we're not hearing those assurances. So this is not about improving care for the Medicare or the Medicaid. We believe that this really is about having access to commercial patients, and what that happens is if you have better access to commercial populations, or commercial patients, then everybody else is left to pick up the pieces, and the whole health system inflates. The whole cost of the health system inflates. So we think about Queens. If commercial moves away, commercial patients move away, and we can't sustain the services like behavioral health services or our trauma services, then all we have to do is, what we do in return is that we increase our pricing, and that increases the prices for everybody else because we have to stay sustainable. Patients are still going to come to our doors. We're still making investments in communities where we know that there's healthcare deserts because they don't have care, and nobody is raising their hand and making those investments in those communities. Not just with hospitals, but with clinics, with providers, with psychiatrists that are desperately needed. So this is, I think that's really important to keep in mind. And so the last one I'd share is that we have done quite a bit of polling, and the polls show that 80% of the community, 80% of those that are asked, think that this is a bad idea. They want change. People clearly want change, but they want incremental change that is realistic, not a major overhaul of the healthcare system. So the independent providers, the Native Hawaiian community, they've all shared those same exact sentiments that we're looking for some kind of change, but something that's realistic. And this One Health Hawaii is not favorable in their minds. So it's still not clear to me how One Health Hawaii is better for our community. It's not better for our healthcare community. It's not inclusive. We are being asked to accept or buy into a concept that's already been pre-baked. But at the same time, we haven't been able to find out, like, what does that model look like? What does it actually mean to participate or not participate outside of the vertical integration? So there has to be more to the motive, and that's what we're curious about. So we appreciate the opportunity to share our story, to share our concern, and we're appreciative that you're asking the questions of One Health Hawaii so that we all get some answers. Thank you.
Okay, thank you. We have Queens here. Oh, I'm sorry, not Queens, Castle here too. Would you like to share?
Thank you, chairs and committee members, for again taking the time to talk about a potentially significant healthcare change for the communities that we serve in. My name is Chase Lawberg. I'm the president of Adventist Health Castle. When we talk about the future of healthcare in Hawaii, the goal should never be about protecting one organization, whether it be a payer or a provider. The goal should always be strengthening a healthcare system that provides access for patients and communities across all islands. Hawaii's healthcare ecosystem is unique. We have a relatively small population spread across multiple islands, a limited number of hospitals and physicians, and one of the most geographically isolated healthcare environments in the country. Patients cannot simply drive to another city or another state, and healthcare systems cannot easily expand here from the mainland. Because of that, the strength of Hawaii's healthcare system has always been about a balance of collaboration and healthy competition. Competition matters because it drives innovation and reduced costs. When hospitals, physicians, and payers operate in a competitive environment, they are constantly looking for ways to improve care. And whether that's expanding primary care access, recruiting specialists, developing new services, or improving the patient experience. Independent physicians and community-based providers are also an important part of the ecosystem. They bring new ideas, new approaches to care, and new ways of reaching patients. Those are the outcomes that should be driven for in our healthcare market. When markets become highly vertically integrated, where fewer organizations control insurance, referrals, and care delivery, there is a risk that scale and size begin to matter more than quality and value. Over time, that can reduce the diversity of ideas and approaches that drive innovation to help improve access and quality. In a larger mainland market, those shifts may simply redistribute patients between organizations. But in Hawaii, where one healthcare system is smaller and more interconnected, the impact can be much greater. In fact, even small shifts in where patients receive care can have significant consequences to access of care. Hospitals are required to maintain incredibly expensive services, emergency departments, intensive care units, specialty coverage, 24 hours a day, every day. Those services depend on a stable patient volume and remain sustainable. When a small percentage of patients shift away from one hospital to another, it may not sound like much, but in a smaller market like Hawaii, those shifts can determine whether a certain service remains available in a community. That's why maintaining a competitive and collaborative healthcare ecosystem is so important to the state. A good example of how that balance can work in the role of a community-based hospitals play. Adventist Health Castle serves the windward side of Oahu. Geographically, Castle is uniquely positioned to provide care for local communities across the windward side, allowing residents to receive care closer to home, quickly and at a local level. Over these past several years, Castle has invested heavily on innovation and expanding access to care for the community, despite challenges at both the federal and state level. We learn to adapt and overcome. Examples of these investments are expanding our trauma program, adding advanced imaging services, enhancing specialty physician coverage, and bringing urgent cares into new communities outside of Windward Oahu. These types of investments happen because healthcare organizations are constantly working to improve how they serve their communities. And that kind of innovation is most often driven by a healthcare environment where organizations are encouraged to continually improve. At the same time, collaboration remains essential. No single hospital or physician group can meet every healthcare need in Hawaii alone. Healthcare providers across our islands work together every day to coordinate complex care, share expertise, and support one another in serving patients. The goal isn't to prevent collaboration or progress. Collaboration is essential. But it is equally important that the structure of our healthcare system continues to encourage innovation, patient choice, and competition based on value. Because of Hawaii's unique environment, maintaining shared responsibility ensures that patients continue to have meaningful options for care. Providers continue to innovate, and communities across our islands continue to have access to essential services close to home. Hawaii is projected to spend nearly $200 billion in healthcare over the next decade. This trajectory underscores the responsibility of every provider and every payer to act in the best interest of their communities, while ensuring that progress is not achieved at the expense of others within the system. In this context, the proposed partnership between HMSA and HPH presents a significant level of risk relative to the potential benefits currently being presented. Patients' access to care, stability of the provider network, and the advantages of a competitive environment under the intense pressure if the partnership comes together. As an example, Adventist Health Castle has consistently maintained top quartile quality metrics and is currently the only CMS 5-star and Leapfrog A-rated hospital in the state. Those metrics have not been recognized nor rewarded by HMSA. Based on the information that has currently been provided to us, nothing in the proposed partnership would appear to change that dynamic. Independent providers have expressed their concern to us that they feel at significant risk if this partnership comes together, leaving potentially significant gaps in care in an already stretched community. The people of Hawaii deserve a healthcare system that incentivizes all, big or small, payer or provider, who deliver the best quality and value. We believe the current plan, as proposed, only benefits few and produces significant challenges for others trying to deliver on access, quality, and cost. Thank you.
Thank you. We have Kaiser here if they'd like to share, but I'm not sure if he's shaking you.
I want to thank the chairs and the members of the committee for allowing us a few minutes again to share some of our perspectives coming from Kaiser Permanente. And really I want to focus on a couple of key areas that many of my colleagues in the room have touched upon, and that being around the concept of natural competition, perhaps some of the concern we have about the loss of that natural competition in the healthcare space here in Hawaii. Also want to bring some clarity to some of the terms that have been used here. Some have brought up the terms of value-based care or accountable care organizations, and really looking at the value of the care. And Kaiser is frequently exemplified as the model of value-based care or accountable care. Maybe the last thing I want to talk about is something that I've brought up in other venues before, and that is around the fragile healthcare ecosystem that we have here in the state, and how every health system, every health plan in the state has a responsibility to support that fragile ecosystem to help create economies of scale in an isolated state that has relatively few resources in comparison to our colleagues on the continent. I'm Ed Chan, I'm the president of Kaiser Permanente Hawaii, and I oversee our operations of both the health plan and the care delivery system here. So while some can have experience in the care delivery system, some can have experience in the health plan, I wear both hats simultaneously. Let me start off by some of the concerns that we've raised with the lack of competition that may be present if the One Health Hawaii merger were allowed to go forward. Some have asked Kaiser Permanente, are you concerned about direct competition or the loss of that competition? And that is simply not the case. More so, we are concerned about the lack of the natural competition that allows organizations to innovate, allows organizations to reach for partnership and look for solutions in a naturally competitive landscape. When we talk about the Kaiser Permanente model or value-based care, that is something that Kaiser Permanente is sometimes known as the pioneer of value-based care, which was created over 80 years ago between the Kaiser Foundation Health Plan and the Permanente medical groups, which operate nationally, including here in Hawaii. In that model, the health plan, the hospital, and the medical group operate as independent but tight partnerships, operating under deep trust, expertise, acknowledgement of that expertise that each one brings to the table as separate but distinct organizations. We believe that, and we believe that our results show, that creates the healthy tension that's necessary for healthcare to truly flourish in a value-based and economical way, while also providing the highest amount of quality and safety to the patients that receive that care. I'll end by also talking a little bit about the fragile healthcare ecosystem here that I've mentioned in previous venues. Although Kaiser Permanente insures about 20% of the Hawaii population, so we have a significant presence here in the state, we also recognize the responsibility that we have to contribute to the overall sustainability of the healthcare systems across the state. And that is evidenced not just here on Oahu, but on Hawaii Island, Maui, and Kauai, where we not only provide services to our Kaiser Permanente members, we partner with local medical groups, including all of the care delivery systems that are in the room today, because we recognize that not any one should dominate the healthcare care delivery, that in a state like Hawaii, we have to partner, and that allows for the healthcare and the access that has been described here in the room to be sustainable for decades to come, because we are lifting up the best of each piece of the care delivery system across the state. So I want to thank you for giving me time to share some of our remarks and some of the concerns that we may have here about the One Health Hawaii merger. Thank you.
Thank you. I also want to note HMA is available on Zoom as well. They're not going to be giving any kind of talk, but if members have questions for doctors and want the doctor's perspective, they are available for us as well. With that, why don't we open it up to questions? I'll start on the House side and maybe we can go back and forth. House members, do you have any questions for any of the members? Yeah, Fred Martin.
I have a question for HMSA, HPH. If in the proposed merger, what would the experience be for small private providers? Now, for example, pediatricians might have that same set fee by HMSA for, a patient per month. Would that continue, or what would be the change for private providers? private practices that are currently part of your network?
Yeah, so just to share, the payment model that happens is a fluid program of the way a health plan, not One Health Hawaii, but the way a health plan interacts with its provider community to ensure the right outcome for patients. So prior to COVID, HMSA had an innovative idea to pay primary care per member per month in order to get them to pay attention to their full panel rather than a fee-for-service model. That started in 2016. It went very well, I would say, up till COVID, when that terrible pandemic shut us down for basically 3 years, and many providers closed their office. Post-COVID, what's happened is a few dynamics. One is that patients have gotten sicker because they deferred care. The habits of care delivery have changed in that there's many more referrals now to urgent care and emergency room than there were pre-COVID, on the order of 30% increases. And we really need a way to get primary care providers to see their patients in office visits more often. That's the world that we live in today. So HMSA, a health plan, is considering changing its payment model in the various lines of business. We already changed it for Medicare, where the patients have been sicker. We need our Medicare patients to be seen by our primary care providers. So Medicare patients are now being compensated to their primary care providers by a fee-for-service mechanism. So that will always be a health plan function, to change the way we pay for services based on what the community needs at a given time.
So so the answer is it will be back to a fee-for-service, or it will be a flat fee per member?
The answer is it will depend on the situation. And currently today, we are paying fee-for-service for Medicare. We are examining what we're going to do with Medicaid, because an AHEAD model is coming out that's going to have a statewide payment model. So we certainly want to align with that in cooperation with the state. And commercial, we are looking at our data and deciding what's the best model. Is it hybrid, where part of your payment is that way? Or is it, do we keep the model, do we change? And that's all under constant review, and that's the job of a health plan. And it will continue to be the job of the health plan.
Chair, thank you.
Yeah, can I ask a follow-up on that? I guess, Ray, you talked about how after the initial compensation model is put together, well, I don't know who is answering, but you know, One Health will put together this cohort, and the insurer and the providers will negotiate a rate, and then I guess it's going to be a capitated rate. It's going to be a value-based rate, right? And then you talked about how other providers might have the opportunity to bolt on. It's going to be, when you say bolt on, you're talking about basically signing on to that initial agreement that's negotiated by the members of One Health, OHH initially, right?
Yeah, so.
I'm really trying to.
Yeah, no, I mean, it's a complex question,
Sure.
so I'm gonna try to, I'm happy to answer it sort of broader, the way we vision it, and then have you drill down as you want more questions. So as each individual provider or provider organization has existing contracts with the health plan. And I won't talk about those contracts because I don't have visibility on them outside of Hawaii Pacific Health. But I do know that so providers, physicians, if you will, and hospitals either contract individually with all the health plans, or they contract as provider organizations. For instance, within Hawaii Pacific Health, we have what's called Hawaii Health Partners, which is an accountable care organization that has come together that includes our 900 or so employed physicians and another 750 or so independent physicians who have all agreed to take risks together, and we share in that contract. Even though each individual provider still has their own contract, it's on those terms. Now, what we envision, we do want to see everybody move to a more value-based model, which in its fully mature state would be capitated payments, per member per month payments that were discussed before. But we also recognize that all providers are not at a place where they can do that today and be successful. When I first started visioning this and talking about it and had my first conversations with Mike Gold at HMSA in 2012, had we been able to do that, we would likely have not been able to be successful at executing on that. Fast forward to 2026, we've got 4 years of track record proving that we've been able to do that. We've been able to provide higher quality of care at a more affordable rate for the population, which represents about 248,000 lives in Hawaii. Everybody won't be able to do that. And so One Health Hawaii via HMSA will have to meet each of those providers where they're at. Some will immediately say, look, we want to work along a continuum that gets us to fully mature value-based care, which would be capitation. Some would say it's going to take us 3 to 5 years, and here's what we need help investing in, whether it's data analytics, building out the provider network, whatever that may be. That's where that second bucket of value creation comes into play. And I fully suspect there will be some providers, maybe those closer to the end of their career, saying, I want nothing to do with that. I just want to continue being paid on a fee-for-service basis, and they're going to continue to do that. Will they have those who choose to continue in that environment, will they have all the same benefits as someone who decides to move along the continuum of value-based care? They likely will not. But those will all be individual relationships and contracts that are developed with HMSA. But the key element here, which gets to a lot of the questions about how others bolt on, from an antitrust standpoint, we believe legally vertical integration does not create a monopolistic approach. We certainly don't believe that it brings harm to the community. But we also know that if we were to try to do that horizontally, for instance, if us and Queens or us and Castle or someone of the like horizontally integrate, that would never pass antitrust muster. But we can come together through clinical integration and taking risk for a population of patients based on outcomes and cost of care. It's part of the Affordable Care Act that came about in 2016. As long as it's on the basis of clinical integration and creating a healthier community or value-based care structure. So we can do that, and that would likely be established outside of One Health Hawaii. We would all participate in, just as independent providers do the same with Hawaii Health Partners within Hawaii Pacific Health today. We don't run those practices. We don't tell them what to do. We don't tell them what their office hours are. We don't even contract for them with HMSA. We agreed to shared outcomes and cost metrics. And that's what we would establish outside of One Health Hawaii, where in the most mature state, we had hoped that all providers and all payers would make that same commitment. And quite frankly, that's when the $2 billion that we talk about becomes exponentially more impactful for the people of Hawaii. So what I'm not saying is that it takes that to happen to realize the $2 billion. But when we have everybody committing to a healthier community, value-based care strategy, that's when it brings its greatest value to the people of Hawaii. And I would suggest, and I may be wrong and I can't speak on their behalf, but if you were to ask any of the folks who just testified whether they believe that they want to create better access, higher quality, and lower cost of care for the people of Hawaii, and that value-based care is a pathway to do that. We may not agree on the One Health Hawaii component of it, but I think we all agree on that. Does that begin? I know it's complex.
Yeah, I guess I think I understand everything that you're saying. My question is around, One Health Hawaii is going to come up with, a payment model for everyone in the One Health Hawaii universe, and it's going to be optimized for the universe of patients and your facilities and your docs and everything, so that you head in the direction you're talking about. If eventually you get a situation where Queens or some other provider elects to join in and bolt on, how will their model not be different when you take into account that they're gonna have a different universe of patients with different conditions and health risks
So,
and cost factors, right?
Good.
There are providers that have older, sicker, or higher percentages of Medicaid patients than you guys. And so if they do elect to come on, how are they gonna be expected to pay within the same model when they have a different group of people that they take care of?
well, just want to say
Sure.
that, Jeff. But the intent that would be, in its fully mature model, you're talking about the bolting on scenario.
I think I'm talking about how we get from here to there. You're talking about here and then when we get there.
Yeah, well, in between,
Yeah.
each would continue to have their, just as Hawaii Pacific Health will still have a contract with HMSA that is separately negotiated. That will happen even within the One Health Hawaii construct. And so every other provider will have that hopefully, if there's a philosophical commitment to move to a fully mature state, that will be moving them along the continuum. That would say, by year 3, we will be doing this, by year 5, we will be doing this. And then we get to the fully mature state, which I spoke of. But when you make that commitment, suddenly we all start taking risks together. Right now, we have 248,000 lives. Right now, there's just slightly over 500,000 attributed lives right now that have selected a primary care provider. In an ideal state, those folks would all come on. So instead of managing as an entity, as a risk-bearing entity, 248,000 lives, there'd be 500,000 plus all the way up to potentially 760,000 lives.
And I stood up, Senator, because you were asking a health plan question. So I just wanted to reiterate that the health plan will still exist. It will exist as it does today. So One Health Hawaii is going to create this strategic vision of let's try and get all providers to value-based payment. Like health plan, HMSA, can you create a payment model for HPH that helps them develop this? And we would negotiate a contract with HPH and it would have value based into it. And then we would turn, since the strategic imperative is let's do this for Hawaii, we would turn to Queens, and we would turn to Castle, we would turn to Independence, and we would say, how would we do this? So like, as Ray said, they're all in different places, and we would have to do it in different ways to try and get to an ultimate thing where we're all on the same model. But in specific answer to your question, they have different patient mix. Some of them are sicker, some of them are older. All value-based contracts have a risk adjustment model to it. So in other words, you get paid for value created based on where your starting baseline is and whether people are getting better or worse from that baseline. And that's called risk adjustment. And the way we do it now is with coding, and they say like, what are the current diseases that they have? And if you're managing 4 diseases, then we should give you credit if you get to 2 diseases. And that's all built into the model, and it's incredibly complex. It is our job as a health plan to do that for each provider system so they can come along the journey, and hopefully at the end, we're all in the same place, and then that's a huge win for the state of Hawaii.
Can I give you a real quick example of how that would look? So right now within Hawaii Health Partners, it's at 1,650 or so physicians, 900 of which are employed by us. Hawaii Pacific Health contracts with HMSA for our employed physicians. We make a commitment on behalf of Hawaii Health Partners on quality outcomes and projected cost outcomes associated with that. Just a little over a year ago, the Filipino Healthcare Association, intact as a separate entity with full identity, agreed to participate with that accountable care agreement. They still have their own contracts with HMSA and have different reimbursement rates based on their individual contracts, but we shared a commitment to outcomes and cost of care. And so that's how we all come together. And what we're suggesting is, once we create the capacity to continue to invest in the ecosystem to allow everybody else to move along that continuum, something very similar could happen. And I think, look, what we're creating is not a unicorn. Vertically integrated systems, open vertically integrated systems exist all across the country, and they've been very successful. This is a little unique because of the size and scale of coming together. But I also think what's unique is that we do have a very symbiotic relationship with the other providers and the other payers in our state, and we're used to working together. Even though we disagree on this issue, we don't all hate each other. We all work together. We all share patients on a daily, weekly basis. And by the way, the far majority of us are all on the same electronic medical record. Everybody who spoke either is or will be on the electronic medical record in the near future. And that allows us to share patients for the betterment of Hawaii. It allows us to share the care and the health of the population management for the almost the entire state. That creates a unique opportunity that I think exists only in Hawaii that could serve as a petri dish for what's possible in other communities who make such a commitment.
So I think my main issue, honestly, with this partnership, merger, whatever you want to call it, is that you guys are sitting here saying that you're going to work together and that everyone has the same goal of bettering Hawaii's health. And I take everyone at their word. I think everyone here is trying to do that on a very high level. But when you drill down, it seems like a healthcare plan and a hospital have very different ways of making money. Their business models are very different. And you two, your two organizations are still going to exist, like you said, under this model, but will have very different fiscal responsibilities to the people that you are representing and taking care of. So HMSA will have a fiscal responsibility to its members, to the insured, trying to get them the best coverage possible, the best care possible, the lowest premiums possible. That is not what HPH's main concerns are. And I understand that One Health is going to be kind of an overarching entity. My concern in what I've been hearing is that One Health will be essentially in control of both organizations and have decision-making authority. So maybe I do want to drill down into governance for a little while. Because your organizations have kind of been against each other as far as priorities for so long. I mean, I think health insurance and healthcare naturally have conflicts. I think everyone here will admit that.
Yeah, I actually.
Will One Health Hawaii be the decision maker? Will you be able to override as One Health Hawaii either organization's decisions?
Well, there's a lot baked into that. First of all, I would say I don't think our financial interests are as different as it may appear. I think there's been a misalignment in the way that healthcare is designed to be funded. But one of the things that I'm most proud of, frankly, of every organization that's represented, but certainly of Hawaii Pacific Health, as someone who's been leading it for a long time, and as HMSA, we are very lucky. We have all not-for-profit 501c3 or community benefit organizations servicing the health of the people of Hawaii. And I think we all have stood up in a very strong fashion representing what's in the best interest of Hawaii. I was proud to see what Queens was able to do during the pandemic. I was proud to see what Kaiser did. I was proud to see the leadership that HMSA provided. And I was certainly proud of what Hawaii Pacific Health provided during the pandemic. I was proud to see the way the system came together when we had that tragic event on New Year's Eve with the explosion, and it took every single one of our health systems to come together to do that work. And so I think we have a long history of doing anything but being profit motivated and pushing for our own financial well-being. We make investments in things on a daily basis that make no economic sense.
I understand that, but you also said that you're going to still be negotiating directly with HMSA, even under One Health. That negotiation wouldn't be a negotiation if you were all on the same page. You're going to be pushing against each other, even under One Health. So my question is, will the One Health organization be able to, while you're negotiating with each other, overrule either of the organizations on decisions that are being made?
There's certain delegated authorities that will remain either from a regulatory standpoint, from a statute standpoint, that remain with those relative institutions. We will certainly do broad scale capital management. We will be determining strategic investment opportunities. But again, this is something I know it sounds difficult and maybe somewhat unrealistic to believe, but I live in this world every single day. I've got Hawaii Pacific Health, which is a parent organization over 4 major subordinate entity hospitals, Kapolei, Straub, Wilcox, Polimomi. Each of them have their own medical staffs who act independently. Each of them have their own boards that approve the medical staff privileges. Each of them have their own budgets that, yes, roll up to a combined Hawaii Pacific Health budget. Each of them make their own capital budget decisions consistent with the strategies and priorities developed by Hawaii Pacific Health. And I would see One Health Hawaii filling that exact same role. This is familiar territory for me. There are certain things that are best served closest to the patients we serve, patients are closest to the members, and then things that serve in the best interest statewide. And that takes clarity in the governance documents, which have been created, which have been approved by both of our boards, which have been submitted as part of the regulatory filings, and clearly outline these. And further, we have great trust in the responsibilities of the Department of Justice, the Attorney General's Office, the Insurance Commissioner's Office, and SHPTA to provide regulatory guidance and oversight about how we make sure all those lines remain clear. This isn't a free-for-all.
So you're saying that when you conflict, I mean, let's say per member per month versus per procedure kind of reimbursement. I mean, if you folks are, if your organizations are fighting each other on that, will One Health be able to step in to make that decision?
One Health will provide the overarching strategy. The overarching strategy of One Health Hawaii is to move to a more value-based care, healthier communities strategy,
So
which
if
we
they
believe.
believe that value-based care strategy is to have per member per month, are they going to be able to override one of your organizations who thinks differently?
One of our organizations won't think differently.
It's not a great answer to that question.
No, it is. I mean, within Hawaii Pacific Health, when we sign on to creating One Health Hawaii,
I mean, you're saying that you folks will agree on everything.
no,
That's the
I'm not
only
saying
way
we
that
will
seems
agree
to
on
be
everything.
true.
What I'm saying is we will agree on a value-based strategy, which we do. That's why we're coming together. That is the principal basis of why One Health Hawaii is.
If you guys already agree on everything,
just,
why are you making this One Health entity?
So you're actually asking a insightful question, Chair, that is actually a challenge in all of these. And so I'm gonna just tell you a story about what happened. Do you guys watch The Pit? Have you seen the?
Love that show.
So The Pit is at Allegheny in Pennsylvania. And Allegheny did exactly what we're doing with Highmark. They created a parent, Highmark Health, and then the health plan Highmark and Allegheny Medical Center are.
You've seen the Pit, that show, that's maybe not the example you want to use for good healthcare delivery.
But I just wanna tell you the story about how.
It's pretty accurate.
And then University of Pittsburgh Medical Center, the university hospital that does most of the tertiary quaternary care, was a big opponent when that thing came out. It's kind of like it's a story that is similar to what we're facing here in Hawaii. And what's happened 10 years later has been a massive reduction in the cost of care in the Highmark network of 5%, taking out of the cost of care. And UPMC has grown their market share by being able to focus on the parts of the care delivery system that.
Right, we're getting a
Yeah,
little off
okay,
track here,
but
though.
the reason why I'm telling this story is Highmark is a blue plan. So I sit with their CEO every quarter, and how's it going? Like, what's happening? And he shares exactly what you're talking about. In the first years of the integration, there was still conflict because it's still a payer and it's still a provider, and they're still arguing over what's the best way to get to value, and there's still disagreement. What doesn't go away when you integrate is the art of compromise. We still compromise, right? And we still figure out. The difference is the compromise now takes place within a boardroom instead of across a negotiating table. Today, when we cannot compromise or when we're struggling to compromise, somebody says, I'm going non-par. The health plan goes, okay, you guys do whatever you want, we're out. Like, that doesn't happen anymore in an integrated scenario because you have to solve the problem. You know the story about lock the doors until they find a solution? That's what happens in a situation like this. And that's what happened with Highmark and Allegheny. So was the pace of change like constant? No, it was slower in the beginning. It was like people adjusting to the new thing. And eventually it got to a great place. And now the people of Pennsylvania are benefiting from the whole structure. And that's what I envision this is gonna look like once we get started.
Okay,
So if I could, because you said that wasn't a very good answer. I stand by my answer. Because, and I'm not trying to be bullheaded, I'm just trying to be very transparent. The reality of it is just take it as an example within Hawaii Pacific Health today. Very similar structure. If Wilcox decided somehow that they didn't want to be part of a value-based care environment, that couldn't happen because that's inconsistent with the strategy of Hawaii Pacific Health. Now, how the individual provision of care and how Wilcox gets reimbursed within that value-based structure is all up for negotiation and part and parcel to the contracts. But the strategy itself, focusing on value-based care, is not something that everybody gets to choose their own pathway. That's not. The intent is to move the collective organization for the community good.
But what you're saying is that you'll just work it out. And right now you are currently status quo in a position where you need to work it out. What you guys told us last time when you were here too, was that the board of One Health would be evenly divided between HMSA and HPH. In that case,
That's
would
not,
okay, is that different than?
no, what we said is just 13 members, 2 of them would be the 2 of us ourselves, an even number from each of our entities, and even a greater number from the community at large who currently do not serve on either of our boards.
Okay, so there will be independent members on that board.
Well, all of the members of the board will be legally deemed independent, but there will be more, the majority of the new board relative to each of our organizations will be new members who don't serve on either of our boards at any level today.
Okay.
So okay, I'll just share the numbers. I don't know if I'm supposed to do this or not. There's 13 members, the 2 of us, 3 from each of our respective entities, so that's 6, and then 5 from the community at large.
Okay,
That's the way One Health Hawaii board is made up.
I do want to delve into that more, but I don't want to take up too much time all at once. Does anyone want to?
Yes, I've
interject?
got a number of questions. Okay, so I went to the first informational briefing, even though I'm health and not CPN. And I'm not quite sure why I'm even here, but regardless, but I'm health chair.
We're happy you're here.
I'm health chair, so as health chair, frankly, I'm a bit concerned now. I wasn't that concerned originally about this because I understood that it was a vertical integration. You folks are looking at accounting integration, administrative integration. But what my concern is your answer to Rep. Matayoshi is that now One Health is gonna be determining strategy based upon a value-based system, in which case now it feeds into your opponents. Their concern is that you guys are gonna start offloading acute patients with high needs that are not gonna give you guys the value that you need to keep your one,
So value-based care does not mean
so,
cheap.
okay, no, you know what?
Highest
Why don't
quality
I start
and
off with my
effective price.
original question, which, and I apologize, I was not here in the beginning, the half, because I didn't think I was invited until now. But anyway, how far you guys are you on the integration? Because originally on the first
We're
informational.
zero, because we're not allowed to integrate yet until we get regulatory
No,
approval.
but you said that the governance documents were submitted somewhere. Where?
To the Department of Justice.
Is that public documents? Is that something that we can all look at and start picking apart?
They're not. They're submitted to the regulatory body, and unless they release them.
When do we get to see public documents as to your integration? Because otherwise, we're just surmising what you folks are going to do. I do not watch The Pit, okay?
But
I'm as concerned as they are that you folks are gonna start offloading patients with high needs because they're not adding value to One Base Hawaii. When are we gonna see those? And frankly, I didn't take much from the first informational briefing because, we're just speculating. And it sounds like we're still speculating now.
well, so a few comments. One, we specifically said that One Health Hawaii would drive strategy in the previous hearing. We said that. The second piece is the reason there's a regulatory review by the Department of Justice and SHPTA and the Attorney General and the Insurance Commissioner's oversight is because those are the bodies in which we are required to submit those documents to, and we have in good faith and trust that those will get appropriate review and appropriate adjudication and apply appropriate conditions if they so desire. Those documents are not open for public review yet because they're in the appropriate regulatory body. That's the way the process works. You all, I assume, established those processes and those offices
When do
for
we
just
start
that
seeing
purpose.
the public, when does the public get to see these documents so that we know what we're looking at and whether or not we have any kind of input?
I'm
Because
not
we're
sure.
all concerned, okay? I am concerned about the health insurance plans folding, and that's why I could see this as a strategy for you folks surviving. So I'm in favor of you folks in one part, but I'm also starting to hear disingenuousness as to your presentation, because originally I thought it was just an administrative integration, and now I'm hearing this strategy which kind of scares me, and it kind of scares everybody, frankly.
Let me step in for 1 second. So those filings are not public yet. One of the reasons we're having this info briefing is so we can ask them questions about it and try to get more information from them. So although I don't think they can give us the full filings, they are here to answer questions about it for our concerns, which I appreciate. But I sympathize with your frustration. I see your frustration too.
Senator Joy, I'm sorry, you missed my comments in the beginning, so I just, if you indulge me, I'm just gonna read them, it'll take 30 seconds. Because it specifically answers your question about whether or not we're going to shift people, like the healthier patients, to one place or the other. And this was, I specifically said that. You've heard concerns that this model could somehow shift healthier, better paying patients to one system and leave others with a disproportionate burden of more complex, lower paying patients. So let me be very clear. Number one, that is not the intent of One Health Hawaii, and it would not be allowed to happen. The model depends on maintaining access, protecting safety net services which are provided by all the health systems in various ways, because they all do, and ensuring patients can continue to see the hospitals and doctors that they choose. It also can't logistically happen because there's no capacity in any one place to move anybody there to be selected and shifted. We lack access everywhere, people are waiting too long everywhere, so.
Okay,
it's not
so-
logistic. And the last point is that we operate in one of the most highly regulated environments, and specifically things like network adequacy, affordability, the way care is delivered are regulated thanks to statutes put into place by this esteemed body. The Insurance Commissioner, the Attorney General, and other regulators specifically tasked making sure that it's accessible, affordable, and fair.
Okay, so I'm just gonna follow up a little bit.
And we'll be glad to follow up.
Okay, so one concern, the biggest concern is the offloading, right, of
I'll show you-
non-value-based patients who would take more from the system. And one example, frankly, that I've heard of recently is that some Molokai patients are not being accepted by STROB. And
Well, I was about to ask you, have you ever heard of us turning a patient away?
and I've got a list of at least 5 patients from our Molokai senator who are saying that they are not being accepted by STROB.
Well, I would love to sit down with Senator DeCoy if that's true,
Okay.
because I've personally taken calls and facilitated access from her multiple times over the course of the last,
And
12,
frankly,
18 months.
and that's the reason I'm starting to get concerned, is because I haven't heard those lack of access other than the whole airplane issue of not being able to get into Oahu until recently. And all I could think about is the possibility of getting of this integration. And thank you, Rep. Matayoshi, as to allowing us to ask questions now. But you and I are lawyers, and we know that we have to look at the contract in order to find out what's going on, right? And so, and I have real problems in not being able to see the documents themselves so that we could ask the right questions.
So just to be clear,
Just
Senator,
run
the
the
reason
process
why
out.
the documents are not public is because in order to generate a credible business plan, we literally threw all our data in there.
Okay,
And they threw all their data in there. So people know their pricing, they know their patient mix, they know what we do with everyone. And so the regulators look at that and they can say, all right, how does that shake out in the market? But it's not something that unfortunately can be publicly facing. It's very sensitive and proprietary.
And before I think we've got a long history of caring for the well-being of this community, not turning patients away, taking patients regardless of the ability to pay. And so if you've got names of patients where we've fallen short on that, I want to hear those.
okay. I'm gonna hold you to it. Go ahead.
Vice Chair?
Thank you. Let's see. I think it's a two-part question, maybe from you folks, and then I'm curious to hear from HMA. I think I heard you say that there's like broad consensus in our healthcare system that value-based care is the direction we want to go in. And my understanding is that One Health is expanding that beyond primary care to specialists and the broader healthcare system. But that HMSA has already been doing that with primary care providers, and HPH has already been expanding over the last few years. Is that correct? Or been expanding that model to global capitation? Yeah, okay. I guess I'm trying to make sense of hearing conflicting things from different stakeholders about the success of that model, because you folks say it's great, but then you also are describing yourselves as operating at a loss after now a few years of using this model. A survey of physicians found that 77% were unhappy. Of course, it depends on who does the survey and who they're asking. So my question for you is, do you have strong data to suggest that that model is improving costs, access, and outcomes for patients? And then after, I would like to hear from HMA whether there is broad consensus among physicians and other healthcare providers that this model is the direction that we want to go to, not just for primary care providers, but for providers across the system.
So I just want to start by clarifying the difference between broadly talking about value-based payment models and talking about the primary care payment model that HMSA rolled out. That was the infancy of value-based payment in the state of Hawaii. So what we did, is it now 9 years ago, is we rolled out a value-based primary care payment model that was only applicable to the 450 primary care physicians who signed up to do it. And that's actually most of the full-time primary care docs. And as I talked about earlier, it was successful in the beginning, pivoting primary care doctors to think more about the health of their panel rather than only the individual visit. And then COVID happened and things happened and things changed. That is a very limited value-based model that only addressed primary care. What we're doing with Hawaii Pacific Health is a value-based model that addresses total cost of care. So that involves the money that's spent by facilities, by specialists, by all kinds of, the only thing that's not in their model, and I don't know if I'm supposed to say this publicly, but Ray's sitting there, so is pharmacy, drugs. So eventually the value-based model is going to have to start including that because it's such a big part of our spend now, but eventually we're going to try and put it all together. That actually controls cost better. And there is so much data in the local market. The data we have is them because they're the only ones that we're doing that with, and it's been positive. In the country, there is tons of information about where that's worked. The most recent papers have come out recently in the Journal of the American Medical Association, JAMA, talking about, especially in the Medicare Advantage space, how beneficial value-based programs are for curbing costs for sick patients with congestive heart failure and other coronary artery disease. So I hope that answered your question, but I don't want to keep going on. I can talk about this subject forever, but I just wanted to make sure that.
Thank you. Is HMA online? Thank you.
Yeah, HMA, go ahead.
Hi, would you like me to make a statement or did you have some direct questions first?
I had a question about whether there is broad consensus among physicians that that kind of model is working. And I guess the reason I'm asking is because I'm wanting to understand some of the considerations that non-HPH but in-network physicians would be considering as they decide whether or not to join One Health?
Over the course of this hour, so many things have been raised, and it's mixed. But let me try to answer as best as I can. A lot of lofty ideas around mission and where we can and what we should do for the state have been put out. I don't think that there is any lack of consensus from the physicians that we want patient-centered, we want to make sure that everyone has access to care, and that there is a general understanding that there is a not an emergent nature, but somewhat of an urgent nature to fix where we are and how we deliver healthcare in Hawaii. And all of that was raised. To answer your question, I think it's getting muddled because we're raising a concept of a vertical merger or a vertical affiliation, and then we're throwing out different definitions that we started talking about at the beginning that actually sort of conflate. And what I mean by that is, for instance, care coordination. Care coordination, while it is something that all physicians would buy into, we want to be able to move ahead with that. But the issue is that you can do it best when you own and can contain a certain population of patients. And I think that's the nervousness that while we cannot legally see what is going on right now for various reasons of the filings, we do not have enough of the framework of what this will look like. Because whether we speak about care coordination, value-based, all of them require that you can control your variables. And your variables mean that you have a set of patients that you can keep them long enough to make a change. And the minute you say that, from a business perspective, there are going to be patients that you can earn more money with than you can not. And I think that's the elephant in the room. Then who will take care of the rural, the more complicated, the difficult? Will they do that by either not providing services as generously because other health systems or other providers will offer that? And I think you raised that topic because many of our rural and private practice clinicians feel that they're taking a disproportionate role because certain services are not available. And while we are in a more luxurious place in Oahu, they still feel this. And so to answer your question, the biggest anxiety around this is not whether we support it or not support it, but whether or not, how will our biggest fears of how will it affect the larger health system as a whole. Who will have oversight and governance, not internal oversight and governance, but oversight and governance on day zero to ensure that the things that we're most concerned about, we're watching, we can measure, and we can correct it if this should go through. And then the very last one is there's a sense of being asked to weigh in on something when there's not enough specific information. There's goals, there's potential operational models that, by the way, did not work successfully in the past. And if we move forward, how are we supposed to decide whether or not this should go? We should support this if we don't have enough information on the specifics. I don't know if that gives you a little bit of insight.
Thank you. Senator McKelvey?
Yeah. Guys. Since it's all speculative, it makes it a little easier to ask questions at this point. He's right. You guys cross purposes of business models. I'll bring up a great example. So if this goes through, prior authorization will not be an issue anymore under 101. So you're nodding your head yes. So you're saying that you're saying now that we'll never have a physician at HPH saying to us that prior authorization from get the insurer guy to come up. The prior authorization will still be an issue, yes or no? Because I'm trying to get my hands around one of the big issues of cross purposes that exists, and that has always been one of the big issues, has been prior auth. So I'm understanding that this will now be
I will answer, but I'll invite Ed to answer because Kaiser as the ideal integrated model, although ours is going to be open and theirs is closed, like advertises that they don't have prior auth because the integration that they have allows the medical policies of the plan to be embedded in the medical record of the physician. So there is no prior auth because the physician is trying to order something and the medical record is telling them if it's a good idea or not, and asking them to justify it if it's different than the policy or something like that. And it's all embedded in, so you don't have to go through an additional planned step of a pre-authorization, which is administrative burden that nobody wants. So yes, if we are integrated, prior auth as you know it today would go away. Managing your patients to standard evidence-based medical policy would not go away, just as Kaiser would say they do today.
Okay, very good. But I still think it's more about the issue of getting the authorization that the physician feels is necessary, right? And that sometimes there's issues with the necessity of the authorization.
I can speak to the provider side, which is more the physician side. I've never met a physician who thought a prior authorization was necessary. They thought it was an administrative burden because they want to be able to rely on their clinical judgment. But the system as it's designed today requires prior authorizations, and we mutually agree that that brings very little value as long as you're practicing best practice medicine consistent with medical guidelines.
So that would potentially be one of the benefits of this One Hawaii.
That's exactly right. When I talked about where the value creation is, it was about eliminating that kind of administrative burden. The same thing happens with case management. We discharge a patient, we case management alongside with the physician, determine out what the remaining course of care is, whether it's post-acute, whether it's pharmaceuticals, whether it's rehab, and then the health plan does exactly the same. That belt and suspenders would largely, not entirely, but largely be able to go away under an integrated system like this. And frankly, when we create the end state opportunity for caring for a population of patients, that applies to all providers who are part of that risk-based entity or something they're like.
Does that apply to Queens too?
If they join on to the risk-based population of patients.
If they bolt on, then will
If they
they
bolt
have
on,
that option to not have pre-authorization to?
Yeah.
We're talking about integrating into the system where the doctor, if they enter certain things, will automatically have authorization. That doesn't seem to be exclusive to HPH. I mean, Castle, Queens.
We would not intend it to be exclusive.
Yeah, I think you can cite a stat that I think it's 97% of anything that was denied ultimately gets approved. I think that's the right stat. So essentially everything that gets requested, MRIs, CT scans, surgery, almost always gets approved. And so those are things that can go away today. I think it's being bolted on right now or connected with, the vertical integration of One Health Hawaii allows that to go away. I don't think that's the case. So I don't think we want to convolute the two concepts. I think that administrative burden goes away as soon as HMSA decides they want to pull that trigger and say, okay, we're not going to do that.
So just one clarification to the staff that was presented about 97%. 97% of pre-authorizations today are approved, and so we are actively shrinking the number of things that require pre-auth. When we started, I think a lot of you were in the House and Senate when we first started pre-authing advanced imaging, and there was a lot of noise in the community. At that point in time, 81% of images were considered appropriate. And over the course of the 8 years that we've had this program, it's gone from 81% to 97% are now appropriate. So actually, the program worked for the people of Hawaii. It got physicians ordering on the right care pathways and the right clinical guidelines for imaging. And so now we have to take a look and say, we got to that good point, let's back off. But there was a purpose to it. And when you're integrated, you can see that purpose right up front, right up hand, because you're sharing data and the leadership of the organization is looking at the same information.
So I want to allow the health chair to, oh, he's gone. Lost his chance. If One Health does not work, well, first of all, it sounds like you're already on the path without One Health to get rid of prior authorizations. But if One Health doesn't pan out, is HMSA still going to be going down that path to try to eliminate or greatly reduce prior authorizations? Do you need One Health to do this? I mean, it seems like you're already doing it without it. It kind of seems like you're taking credit for, or One Health is trying to take credit for reducing prior authorizations, but not only was it already happening before, but will it already still happen even without it?
Everything that we're trying to do with One Health, we're trying to do without it. But we're not moving very fast. and it's not very effective. You still hear all the noise, which we're trying to control costs. We tried to have value-based agreements with everybody in this room. We have one. And we've been trying as long as I've been CEO. We're trying our best to reduce prior auths, but we're still getting, in Hawaii, a ridiculous 96% of our prior auth requests are coming in via fax. And by the way, can I say we are an outlier in the country? We are the only place where providers communicate with us 96% of the time via fax.
Isn't that on you guys? I mean, isn't that because?
It's not us, it's them. We have a total electronic portal that no one wants to use. They want to fax us the information. So we are right now on this, like, get rid of the fax, thing that we're doing. Our chief medical officer is working
For the
on it.
House members, a fax machine is, you
Yeah.
print out the message, you put it in the machine, and it electronically sends it to another
Senator,
machine
thank you.
in a different office.
So that's why they.
But
I have
but
teenagers.
it is, progress has been slow, and the result has been the result that we have. And most of the things that people have complained about today, or in any other hearing that we have, is a result of the healthcare system today. And all we're saying is, give us a chance to jumpstart it to a better healthcare system of tomorrow, because this one is not working.
Rep. Martin.
So,
I think we need a fact check, and I think all along the things need to be fact checked because Queens and HPH together don't own fax machines, and we have to represent half of the requests, at least, right? And so how can it be 80-90% are fax machines when we know that we're not sending fax requests, and I know HPH is not sending fax requests? So I just request a fact check.
There is no pre-auth for ER, inpatient, or any of those other things. So Queens and HPH are not half of the pre-auth requests. Most of the pre-auth requests come from independent providers.
I just wanted to say that with the prior authorization, we are trying to deal with that issue. We appreciate that you folks are working on it, and that's something that we want to get to regardless. And talking about the imaging, the percentage that are approved going up, that's probably just standard of care has changed as those images have come into use more regularly. It's not necessarily that they were inappropriate requests early on, right? And we want to keep up with whatever the standard of care is. My question is, I feel like what you're talking about is a future situation in which you, as the largest insurer with the most patients, are going to be offer our other hospitals, our smaller or just other hospitals, a kind of a take it or leave it deal. Either you're gonna agree to our terms or not. And I do know that private, primary care physicians in my community felt that way when they were basically, tried your current system, which they still are on and don't like, of, a flat fee per member per month. And they don't have a choice because you're the biggest, insurance company in town. And I feel like our hospitals are gonna be faced with that same situation, that no matter what the terms are, it's gonna be take it or leave it. And it's an all or nothing deal that will be offered to them, and they'll have no choice either.
I can just speak for myself. I can't speak for what anyone might do 30 years from now. But I would say Hawaii is unique. That's been brought up by a lot of people, that we have two very big health systems that supply 2/3 of the care. We have niche markets that are critically important, like, for example, Castle on the windward side, taking care of all the people on that side. We have independent providers who see about 40% of the primary care, so critically important. And then we have neighbor islands, where the Hawaii State Hospital System and their affiliates and many rural providers are key to just anybody having any healthcare at all on those islands. There is no way you can take away choice from those people. They all provide a critical role in the development of the health of our state. And the mission of One Health Hawaii is going to be making sure that the healthcare in the state gets to a different level. You can't do that by taking away choice from the actual people who are there delivering it. what you do is you try and help them find a way that they can take better care of their patients. If it's our model, it's great. And just as I mentioned, 450 primary care providers took our model. There were a bunch who didn't, and they had the choice. It is definitely always a choice. You have a choice in how you work and how you get paid with us. We will work with you in whatever way possible to make sure our members continue to get access. It's our responsibility. We take care of a little bit more than half the people of the state, and we have to make sure they have care. There's no way we can cut out some part of the provider.
Can I add a little color to that as well? Again, wearing the One Health Hawaii hat. I've been a provider on the provider side my entire career. We're coming into this as we consider this an integration of equals. I wouldn't know how to check my provider hat at the door. Any policy decision, any operating decision that's made at the One Health Hawaii, and certainly at the Hawaii Pacific Health level of the enterprise will have the voice of the provider. And the whole intent of this is to get the premium dollar, the dollars that are provided by the people of Hawaii, as close to the provision of care as possible with the least amount of administrative obstruction. The other thing, I don't know if I'm gonna get back up to the podium, but I've already said I've been doing this for a long time, decades at the CEO level, and I can tell you this is now my third administrative briefing during the course of that career. 2 of them have been in the last 4 months, and that excites me. No, it does. I'm excited for the fact that people are starting to have conversations about the future state of healthcare in our community. Whether or not One Health Hawaii happens or not, we've raised a discussion about how to better care for the people of Hawaii. And so while this may at times be painful, I'm glad we're having the discussion, so I thank you for that.
Sorry, let me get HMA on first and then we'll go to Queens. HMA, go ahead.
I want to be careful with 2 things. I want to take back a definition. I think hospitals and healthcare systems are health systems. Providers are people that actually go one-on-one care. So when we talk about collective providers, I think that probably should more accurately represent clinicians, nurses, and such. The question that I have for the group is as this committee is trying to evaluate whether or not this is something that we should move forward with, whether or not it will actually benefit the greater good. The question I have is based on what's been going back and forth and what is being presented, which one of the models that has been used in the past several years do they actually intend to use to move things forward? And I asked that very openly. For instance, you spoke about the payment transformation model. The payment transformation model was not necessarily very successful, and there was a lot of pushback in the community. COVID was the final nail on the coffin, but there were a lot of reasons why it wasn't moving forward as successfully as possible. That doesn't mean throw the baby out with the dishwater, but it does mean what things didn't work. Why was it so difficult to expand into specialty care? And is this the model that even though we cannot see the entire filings, is this the model that we're going to expect to be used if One Health Hawaii moves forward? And if not, what model is actually going to be used? So while we may not be privy to a lot of very private information from the different corporations or the different health systems, I think a general model that we can all understand of how this is going to be made successful would be helpful for at least from the physician or the provider community to understand how we could weigh in on this. And again, not to weigh in to fight back, but to understand what questions should we be asking and what oversight should we ask for at the beginning rather than later on.
Okay, Queens briefly, and then I know Senate has another question.
Yeah, so very briefly, I think that Representative Martin, you raised a really good question that, your providers, do they have a voice? Do they have an option to participate or not? And I feel like that's one of our concerns. So recently, the Medicare Advantage per member per month payment model was discontinued. And the impact to Queens is about $3 million. We've already started to feel that it started on January 1. Not a lot of choice, it's just happening, so you adjust to that. I think the consideration that Mark brought up earlier was that they're looking at doing the same thing, discontinuing the per member per month for the Quest Medicaid population and the commercial populations. And I guess the question to ask is, are your providers or Queens or any of the other providers at the table having any input into whether that is a good idea or a bad idea? Or is that just something that we're going to have to assume? So you move into whatever the new model is in value-based payments. We've already watched a few of these fail, and it's too high risk to have something that's experimental at this point fail, and then us have to pick up all the pieces because it's going to involve the vulnerable populations much more than everybody else.
So, yeah, for HMSA and HPH, I guess we can keep coming back to this question about, whether if it fails or if it's not working or if it's not working fast enough, the suspicion that higher risk, more expensive patients will leak out of the program. We can keep going round and round and taking one side's word or over another's on that. And I don't think it's going to get us much further than we have after these two briefings. You've volunteered to participate in these conversations. I think because of the acknowledgement that after the federal government's review of this proposal goes through, regardless of whether it's accepted or rejected, we're all still going to be here as a community together, and then we got to move forward afterward. So what I'm hoping you can offer for us is, after that review is done and we move forward on whether it's an affiliation or not. Well, and let's assume the affiliation is approved in whatever form it's approved in. How will the public have and these committees have assurance that the commitment, that leakage of patients out of the system will not happen? What are there incentives that naturally exist that we just aren't seeing, or are there mechanisms going forward that the committees can rely on to validate your commitment that the quickest, easiest way to save money will not be just dropping patients out of the system for someone else to take care of?
If I could tack on just a little bit, not just leaking out of the system, but cherry picking off good patients into the system too.
Well, and I'll come back to this this room right here, because Dr. Mugishi, you mentioned Hawaii State Hospital, which is full of people who decompensated over time because they did not have appropriate access to healthcare, particularly behavioral health, which the overwhelming burden of that care is borne by Queens. And so rather than going back and forth and attempting a deposition of you folks here, when you're already going through what I hope is a meaningful and comprehensive process with the federal government, when that's all done, where are we going to be able to validate that what you're saying is happening?
Yeah, so maybe I'll start with a few points, and then I know Dr. Mugishi will have points on this. First of all, we've been operating in a value-based reimbursement contract for the last 4 years, and we haven't shifted any of those patients under that agreement. And quite frankly, again, been doing this for a long time, I wouldn't know how to do it. That's not what we do. The patients come in through the provider referrals, they come in through the emergency room, they come in by ambulance, and we care for everybody who shows up. That's the commitment we made to this community. That's the commitment we've always made to this community. We've talked at both of these hearings about mental health, and I'll look at Jason Chang and say thank you for caring for the mental health population. Chase, thank you for caring for the mental health population, just as I would hope that they would thank me for caring for the tertiary pediatric population of the patients and the pediatric oncology patients and the far majority of the burn patients. That's the way we work as a community to create. We don't duplicate services when we have a finite amount of resources to make sure that we do those services where they're best served. okay? So that's one assurance. Further, I would fully anticipate and welcome, I'm curious.
I'm sorry, are you saying that because they do it better, they should be doing all of it, the behavioral health?
No,
Because what I've been hearing is that a lot of the times when a patient shows up at Straub, because you guys have insufficient behavioral health facilities, they get shipped over to Queens, and Queens takes care of them. But what you're kind of saying right now is we don't want to duplicate it, therefore they should take all of them. That's not.
No, what I'm saying is it would make absolutely no sense for us to open a behavioral health unit at Straub. There's not enough volume to support financially
No,
another.
but Queens can't handle all of it. I mean, it's getting, all the crap's getting shuffled onto Queens.
Jason, I'm gonna invite you into the conversation. Would you agree that it's not worth duplicating?
I think I would like my question to be answered first,
Yes.
and then we can go.
Thank you, okay.
And then we can go into that.
Yeah,
Because this is not an insignificant conversation, but I asked one question and I like
Okay,
to.
so further to your question, I also believe that there will be regulatory conditions either by the DOJ or the State Health Planning Commission to make sure that we don't that we don't shift patients or violate what they would see as inappropriate patient shifting or turning away patients and things of the like. I don't know how they're going to do that. I don't know what those conditions are gonna be, but we are more than open to having those discussions with them to make sure that happens. I can tell you, as someone, and I think Dr. Mugishi would say as well, if we're gonna be leading that organization, we would never do that with intent. That is not who we are, that's not the way we've led the organization up to this point, and it's not a practice we intend to start. But I also suspect it will be regulated.
So I appreciate that. That's a meaningful answer. And then we gotta wait and see on that as a function of the agreement. But if that is the answer, then what assurance do we have that Mahalo Health System in the future elects to bolt on to your program after it's approved? In the near future, yeah. Health System X, Mahalo Health System, elects to bolt on, and 6 or 8 or 12 months go by and it's not working, and they decide to start offloading patients.
They wouldn't be in our system for very long. We would.
And what assurance can we look to that scenario won't happen?
Yeah, so, again, we're gonna be, we're going to be subject to the same regulatory scrutiny as we are today as a health plan, where we're not allowed to say somebody's too sick, so we're cutting off their insurance policy. They're not allowed as a health system to say, oh, this person's too sick, let's not take care of them. So we're gonna be subject to the same regulations. And under statutes, for us, the insurance commissioner, for them, SHPTA, they have to monitor what we're doing. Are there specific metrics that would monitor what you're asking in the context of this? Not yet, but as Ray said, let's develop them then. If that's the obstacle to getting people to trust us, let's sit down with the insurance commissioner and say, okay, what metrics do you have that you would like us to measure to make sure this is not happening? And we would do it.
Well, so that's a fair commitment that I appreciate, because having individuals move from one, leakage is not an appropriate term, and I'm not familiar with the proper ones, but having folks go from one plan to another can happen for lots of different reasons, subtle but potentially pernicious. And because we don't have the decision-making authority on this transaction, but we have the responsibility to deal with the after effects, that's a question that I would like to continue to have your commitment that we work on.
100%. And our actions, I think, would
regardless of
demonstrate.
outcome of the federal process.
Yeah, and our outcome, I think our actions up to now should give you assurance that when we say we're committed to do that with you, we will. We cover just about half the people in the state. We cover much more than half of the Medicaid population. Medicare Advantage is not a profitable business to us, but as a community benefit, mutual benefit society here, we are not like the other blue plans closing our Medicare Advantage. We are doing them because that's part of our responsibility to the community. That is just our actions which show that we are committed to work with you on that.
And further to that point with Senator Joy's question, since March 16th, there were 6 patients referred to Straub from Molokai. We accepted 4 of them, and 2 of them were not accepted. 1 because we didn't have the capabilities, and 1 was a very specific hemodialysis service, which we could not care for that patient. And I understand that some of those points that you came up with came out of a Lanai community meeting, and so I'll track those down as well.
Thank you.
Okay, behavioral health is coming back, but first, Vice Speaker.
For HPH and HMSA, can you please help walk us through the process that you folks are undergoing here? Because I think there's a lot of confusion, kind of along the lines of Chair Buenaventura's questions. So you've submitted something, filing with the Department of Justice, and then they give you a letter? They give you a...
No. So we submitted a filing, and it first was determined whether it would go to the FTC, the Federal Trade Commission, or Department of Justice. It was found that Department of Justice would adjudicate this and have jurisdiction. They are now following up with inquiries, asking questions. My understanding, they were in town last week interviewing folks. They're doing telephonic interviews, and they're doing their inquiries. They will have, at the end of a date that's coming up within the next couple of weeks, they will either ask for a secondary review or their inquiry will be completed. Regardless of whether it's at the completion of this 30-day period or completion of the secondary inquiry, time will just elapse. There will be a time in which they stop asking questions. We make a statement saying we have substantially responded to those questions, and then there's a clock that ticks. And then when that clock expires, essentially we have clearance, not approval, clearance. The only option that the Department of Justice has, if they oppose it, would be to file a lawsuit in federal court to oppose or block the vertical integration. They do not have approval authority. It gets clearance with questions being asked and answered and time expiring. And then if they oppose it, they file a federal lawsuit in federal court to block the integration. That's on the Department of Justice side. Where we're at now is in discussions with SHPTA because it has to be decided whether or not it goes in different directions, whether or not it's going to be a certificate of need or a change of ownership and things alike. As soon as we've made those inquiries to SHPTA, and as soon as we have final validation of which course that will be, we will file with the State Health Planning Department as appropriate.
Is it same for the insurance commissioner?
Yeah, the only thing I would add to that, well, 2 things I'll add, is number 1, prior to the Department of Justice even becoming involved and being us filing our papers with them, the State Attorney General initiated a legal review of this transaction and required us to submit a bunch of information to them, which they have been reviewing and doing interviews of their own. They're looking at it from the anti-competitive standpoint and some of the other questions that you have, the committee had. They are now doing a lot of things jointly with the Department of Justice, but their authority is for the state, and they can choose to go along with the Department of Justice or issue their own findings or whatever they choose to do. For us at HMSA, we did work with the insurance commissioner. He and his department did review it. They saw no concerns from their perspective in their jurisdiction.
Okay, so do you have to wait for the Department of Justice to either give you a clearance or the clock runs out before you go to SHPTA?
No.
No, it's
They can
happening
be
at
done in parallel.
the same time.
We would anticipate in relatively short order, we don't have an exact timeline, but in the coming weeks, we would have clarity for SHPTA and be able to progress in parallel.
And how long does the SHPTA process take?
Depends on the path. It depends on if it requires public hearings and things of the like.
Okay, and then.
But it's months. It's likely shorter than a secondary inquiry from the Department of Justice.
The SHPTA part will be shorter.
If the Department of Justice goes to a secondary inquiry. We don't know that for sure, but because that could take a month, it could take a year. we don't know from, it just depends on how many questions Department of Justice asks.
Okay, so this last question, what is the outside or latest date by which the Department of Justice review ends, or there is none?
There is
There is none, as long as they are, have expressed continuing inquiry.
Just for all the attorneys in the room, you'll appreciate this. The reason why it can take a long time is second reviews typically involve depositions of all relevant parties, like formal legal depositions. You know, sorting through all the emails that happened during the creation of the transaction. Every time I text Ray,
messages.
they will look at those. So that's what a second review is, so it can take a long time.
Okay, so I guess the reason why I'm asking these kinds of timing and process questions is I think there are some who would like us to take action this session to address whatever future outcome One Health Hawaii would be. But I guess I'm wondering, is it premature because we still don't know what's gonna happen at the DOJ level either way?
Well, can I respectfully submit that, I would suggest that's what the regulatory bodies, the SHPTA, the Attorney General's office, DOJ, and the Insurance Commissioner's role is, that I believe you created, is their roles to provide the regulatory oversight of this versus the legislature itself. But I can't, I mean, that's just an opinion of mine, but that's.
And an opinion of mine is that they are doing their job, because we are getting regulated pretty thoroughly.
Okay, thank you, Chair.
Can I ask a very quick follow-up? I know that it's not public information, but like in very broad strokes, can you paint a picture of like what kinds of information is in the filings? Because I guess I kind of thought that this second info briefing, we would have a greater level of detail in your responses, and yeah, so I'm just curious.
So I'll tell you what's in it and what's not in it. So what's not in it is in answer to Nadine's question about, we need to see the model that they're gonna have. Like, that's not it. Because the model that we're gonna have is something that the management of One Health, the board, the individual companies, HMSA and HPH, in their negotiation will develop over time. We can't have our relationship with Queens, what kind of contract we're gonna have in there, because we don't know. We're gonna have to go through it. So none of that's in there. What's in there is all the data that shows the value that can be extracted. So it's all of our claims data, all of our, the patient data that we share jointly. And if you had an integrated entity, here's the cost that can be taken out of the system. And that's the reason why it can't be public, is because it's all our proprietary information that they're gonna go through and say, are they saying they're gonna really like improve experience? They're gonna really cut costs? They're saying they're gonna do it this way. They're giving it to their actuaries. Is that a credible answer? Like what, are they, what they're saying a reasonable expectation of what will happen? And then the second question they're asking is, could it actually happen without them doing this? That is, and that's some of their secondary questions. Okay, we know you're already addressing pre-auth. So tell us why you need this. What is the differential value of this compared to what you're doing today? So those are all things that they're asking in their regulatory review.
Also submitted with that was a third-party actuarial validation of this savings opportunity.
She's getting a fast.
Here you go.
No, actually, no, maybe it was too early this year, but we did have Senate bill this year, 3175, that looked to adopt what other states have done, because there's vertical integrated health hasn't been all roses, sorry. Other states have put in laws, you guys texting each other in class, to give the legislature basically approval ability if consolidation, merger, call it what you will result in a certain amount of market share, a certain amount of the population now, the services of which are being controlled by one entity per se. And it's because of all the unknowns. I guess my big unknown still, and I'm glad my friends from labor are here, is it appears a lot of the cost savings could be achieved and may be achieved through reduction in staff. If you become more technological, more value added, more outside tech company investment to adopt early adopter systems, I mean, that's a concern I have, insofar as does value added mean layoffs and reductions and more outsourcing? Does it mean that HPH will now become a mail order and the pharmacies will close? Because that's something that HMSA obviously has been near their heart for a while. So these are my concerns. I'm not asking for an answer now because there's nothing to really discuss. But what I'm telling you is this is one of the overarching concerns. Why I put the bill out there was to give the legislature potentially an ability to have a way in to make sure that what is being said to us, what is being filed, what is being approved is going to be the reality. Right.
So, you know, I'm sure there's legislative packages in other states that I haven't seen, but I also understand that the far majority of those were not targeted to not-for-profit vertically integrated systems. They were targeted at the for-profit where they're feeding the pockets of shareholders and the like. And those are largely related to things like United and Optum and Cigna and Aetna and Walgreens and CVS and those types of vertically integrated systems that are driving costs up, driving the cost of pharmaceuticals up, and creating profits for companies and shareholders. This is not that kind of vertical integration, and I don't believe that's what the legislation that has been moving through the country is targeting. Further, what we shared at the last informational briefing stands true today. Because we're not two organizations that are in a state of distress, we have the ability to create opportunities through attrition and through, of course, leveraging technology. The reality of it is if we're going to create value, if we're going to bend the cost of the rate of increase, we have to become more efficient, and we will pull many levers to do it. But there are no programmed increases in market share, and no program which gets to the transition of patients, and no programmed reduction in forces through layoffs and things of the like.
Yeah, and the only thing, I agree with everything Ray said, and the only thing I wanted to add is that, of course, our consolidation of some services will provide some administrative savings, but the intent of this is not to cut jobs and, get rid of infrastructure that is necessary to deliver care. The fact of the matter is, HMSA is we've taken $5 billion of revenue, and 300 million of it, which is just 6%, is used to administrate that amount of money. And all the rest of it, 4 billion.
We just had a major reduction in force just recently, right? HMSA.
It's our job to evaluate programs. What we didn't reduce force. We looked at our care coordination program and we said it wasn't generating the outcomes that we needed. So we restructured it. It meant that one portion of that we had to stop doing that and repurpose the people to the other. And a bunch of people didn't want to move from that job to the new job. And that's what any big company has to do to continue to maintain its responsibility to the people who purchase our services.
Thanks, Chair. I want to do this as quickly as possible, and I first want to state that my biggest concern was the fair treatment, and I know that question can't really be answered at this moment. And then Vice Speaker asked about my second question, which is the schedule. So I just have a clarifying question, and that is, you mentioned that these federal agencies are doing their job, and once they approve or reject, they're either going to provide you some sort of report or summary or whatever that looks like. Is that information going to be public information of why they accepted it or rejected it, or is that going to be proprietary information and not be shared with the public? Would like to understand what your thoughts are. And I also want to just finish with this. You mentioned that those agencies are doing their job. I honestly believe we also have a role in this. And that role to me is not to rubber stamp just whatever the agency has approved, another facts. So I just want to state that I don't think we're provided enough information to really make a decision. And I think what those regulatory agencies are going to provide is gonna help supplement the information for us to make a better decision.
I gotta be honest, I don't know what the Department of Justice will make public, when they provide clearance. And again, clearance means that they just say the case is closed, they're not filing a lawsuit unless somehow they, through some mechanism, they provide conditions, or more likely what I suspect will happen. Again, we haven't been through this that has required this kind of scrutiny before, but what I suspect will happen, they will provide feedback to the Attorney General's office, who will work with SHPTA to impose the conditions that need to be imposed. That's what I would envision happening. But right now, I will tell you that there were interviews as happening as recent as last week on the ground here. I know there's continued telephonic interviews, and I know it's Department of Justice and the State Attorney General's office doing those interviews together. And I know how those work because I participated when we were supportive of the inquiry that the Department of Justice did when Queens was acquiring Kahimahala.
Okay.
I've got a quick question for HMSA and then a longer question. But the quicker question is that you folks are a mutual benefit society owned by the members. Are the members going to get any kind of vote on the One Health partnership merger, whatever you want to call it? Because it does seem like the members have more control over HMSA right now, but HMSA as a whole is about to cede a lot of authority, if not all authority, to this more One Health organization that can now override the members' interests. So are the members of HMSA going to have a say in this?
Our constitution does not require a vote for this, so there is no vote, but they are not, HMSA is not ceding any authority that the members own. The control of the risk-based capital, which is there for the protection of members to make sure that they can receive coverage under any circumstance, firmly sits under the jurisdiction of HMSA. That will not cede it to One Health Hawaii. And actually in the definitive agreement that we signed, we absolutely, not only statutorily is it protected, but we protected it in our agreement as well. So control over that, control over all the functions that HMSA has as a health plan, to issue competitive products, to provide coverage for the members, to administer benefits, all of that will remain in the entity, and the members will still have full control over all of those functions.
And One Health will not have control over any of that. Okay, no, thank you. That's very comforting. The second, more longer question, I think, is on behavioral health and Medicaid. And again, what I've been hearing is that one of the reasons why when a patient walks into your emergency room, they might be then later transferred to Queens is because they have behavioral health problems. Queens has a much more robust behavioral health facilities, so they're transferred. I know Castle does as well. So they tend to get shuffled off to them, and by pure coincidence, those are the ones that are the most difficult to deal with, the most costly. When One Health is formed, or if One Health is formed, I don't see, and I haven't heard anything here that would indicate that One Health would, I don't want to say force, but kind of want to say force, that would require HPH to start taking on more behavioral health. And in fact, what I've heard is kind of the opposite. I've heard you saying that you don't want to duplicate services, which kind of tells me that you're not going to be taking on more behavioral health and thereby not taking on more Medicaid patients. So that's my concern. I'd like you to speak to it, not only in a behavioral health sense, but also in how you're going to be trying to shoulder more of the burden for Medicaid, because you guys keep talking about how great Queens is and how much you appreciate the partnership. That's all well and good, but partners help each other too. I mean, if you really appreciate Queens, and Queens is really hurting from doing kind of the heavy lift on those behavioral health patients, I would think that for the good of Hawaii, which is why we're all saying we're here, that you folks would be trying to take some of that burden, but neither of your organizations, even when joined by One Health, I think have that motivation to take on more of those patients.
So where services reside at individual facilities is a market dynamic that we have collaborated with and coordinated with one another over many years. We see Medicaid patients within Hawaii Pacific Health. In fact, I would argue that Kapiolani Medical Center for Women and Children sees as many Medicaid patients as anybody in the state. We also take care of a tremendous amount thousands of visits per year through our emergency room and through our outpatient behavioral health services, both at Straub, Capilani specifically. Someone shows up in our emergency room with a behavioral health issue, we care for them within their capacity. If it requires a higher level of care, extended inpatient psychiatric care, that patient is best served today at Castle or Queens or Kahimahala, which is part of Queens. And frankly, unless there's a discussion that happens amongst us that determines that there's a need for additional inpatient psychiatric beds and we're the right place to do it, we likely won't enter that market. Because it's for the same reason that Queens doesn't try to take on tertiary care pediatric patients. You have a limited amount of resources, a limited amount of patients, and you want those services concentrated where they're going to make the greatest impact. There is nothing in that model that suggests we're trying to push Medicaid patients to other facilities, because Medicaid patients come in many shapes, sizes, and diagnoses. And depending on what that need is, we take care of them. I can tell you the story of a year that went totally astray for us at Kapilani, where we had 2 Medicaid eligible patients who we kept, young kids who were requiring drugs that were costing us over $100,000 a day to provide that care for cancer treatments. And we did it. And we ran up costs of in excess of $20 million caring for those kids. And if you ask me if I'd do it again today or tomorrow, I absolutely would, because that is the responsibility that resides within the mission of Kapilani Medical Center for Women and Children. And so it's a delicate system. We don't get involved in trauma at the same way Queens does, because if we duplicate that service, it puts that service from a sustainability at risk. And we could go service by service and talk about why that system of care is so fragile. And is it a dynamic being? It is. The answer may be completely different 3 years from now if the environment changes and we see the mental health needs extended beyond what Castle and Queens and Kahimahala can care for. Then we re-engage in those conversations. We have those conversations all the time.
But you guys don't do child behavioral health.
We do, not inpatient. We do the lion's share of pediatric behavioral health or adolescent behavioral health,
But
not inpatient.
I mean,
on
we
outpatient.
have real needs for inpatient child behavioral health, right? I mean, I don't know what the market dynamics are, but I don't think you can convince any member at this table that we don't need more inpatient.
There's a need for behavioral health services across the board.
Right.
It's a matter of how you aggregate those services. But I could see a scenario where if those services are underserved and under resources, One Health Hawaii provides funding through that $2 billion worth of value creation to expand those services. I could see that all day long.
So
It doesn't have to be done in Hawaii Pacific Health.
I think respectfully, I'm gonna hold my ground on that point as well. I think you would struggle to convince members at this table that we have enough inpatient child behavioral health services in Hawaii.
I didn't say we
And the other point I'll just say is, yes, I understand that Kapiolani accepts lots of Medicaid patients, but that's not the same as the Medicaid patients that Queens gets. I mean, even if you have the same number,
It's more actually.
It's
Like
more.
our dollars.
what percentage of them are kids?
Senator, I think you'd be surprised at the types of families that we care for and how many times we have to step in for the well-being.
What percentage of your Medicaid patients are kids versus adults?
Most of them.
Yeah, so kids are
But we wouldn't ask.
Medicaid kids are healthier than Medicaid adults.
They're in the NICU.
They're the sickest
But
patients
the
we see.
NICU is profitable, isn't it?
What's that?
The NICU isn't a loser like the services that are
For a Medicaid patient,
provided.
it is.
I'm sorry?
For a Medicaid patient, it certainly is.
Okay, I don't know. I'm sorry. My mother worked for 30 years in the NICU. For us to be comparing, and let me correct my prior statement. Okay, the services provided in the NICU are critical and really, really important for the community. But I don't think you can one-to-one say that children that are covered by Medicaid have the same cost burden to a health system as adults that are covered by Medicaid. Is that what we're saying here?
No, I just said the number of dollars that we pay out for Medicaid patients, they're number one. But you're right, it's mostly kids. But let me just, explain this principle of providing more services in the example you use of behavioral health for adolescents or children. We are actually short, not just of capacity in terms of a facility to do it, we're short child psychiatrists and adolescent psychiatrists. And if you ask every institution to like set up the same structure, you dilute that out. You dilute out the capable, very capable behavioral health nurses who are specialized in that area, and then nobody actually has the capacity to staff over a period of time.
Right, that's why we want Queens to be trauma, and we want them to be amazing at it. And we might not need more trauma.
And behavioral health, we haven't solved the problem yet because obviously there's a big need. But the same issues will arise if you try and just say, let's just blow it up and have it everywhere. Like you're gonna run into staffing problems, you're gonna run into like all kinds of issues about how you're doing it. And so it's a difficult problem to solve. I'm not making light of it. It's obviously a big deal to us in Hawaii, but it's not as simple as saying, Straub open a behavioral health unit with what? With what are they gonna do that?
And frankly,
$2 billion.
That's what I'm saying, you've already committed, it sounds like, to give these guys part of the $2 billion, right?
That'll be
Yeah.
recruiting new behavioral
That's
health
right.
specialists, but
That's
we might not, if we recruited new behavioral health specialists, it might not make sense to put them at Straub. It
No,
might
it makes some sense to
give them
support
to
these
Jason.
guys.
Well,
Like,
that's what I'm saying, is give them some of the $2 billion. The
that's-
point being
That's
is
bucket number
that
2.
rather than putting everything on them, if you're not going to enter this area per se,
But today we don't have that
You
capital.
resource it with that $2 billion.
That's why we wanna
That's right.
find a
Well,
way.
but this is where I start to, this is where when I hear you guys take a significant amount of Medicaid patients versus Queens. I mean, I understand you have kids that have very difficult and very expensive conditions to take care of that are Medicaid patients, but the older, sicker, more expensive patients with multiple conditions that are very expensive to take care of aren't.
We take care of those at Straub, at Polymomie, and at Wilcox as well.
Yeah, but I'm finding it hard to believe that from a percentage standpoint, it's equal. Adult
But
to
it's
child.
respectfully, you're correct, that Queens takes care of more of the older, sicker Medicaid patients. That's the situation today, by the way. So I just wanna clarify that this is not One Health created this discrepancy. That's what the market is today.
Right, but we're talking about what's gonna happen with the savings.
We'd like to invest in all of these things.
We'd like to invest
We'd
in
like to
supporting
invest in
Maui
making
developing, we'd like to invest in supporting Maui.
problem
Remember, I talked about the second bucket, reinvesting in the healthcare ecosystem. That's getting to the right care, to the right place, at the right time, through the right provider. Never did I say that all that care was gonna be provided by Hawaii Pacific Health. It should prop up Maui Health, it should prop up Hilo Medical Center, it should prop up services that are in need at Queens or at Castle, wherever those services are best served, that's where we need to reinvest those savings.
So okay, that's a worthwhile answer, I think. But now I'm trying to figure out how, when you talk about we need, specialty providers that can work in these different areas, and we wanna concentrate them in these centers of excellence is what I've heard
Fair enough.
before, right?
Yeah.
Okay, I'm learning the terminology, right? But how are we gonna transfer the savings you guys get through One Health into higher reimbursement rates for child psychiatrists that are gonna operate at Queens?
It may or may not, you can answer this better than I can, higher reimbursement rates. It may be just investment in a service line. It may be just sending a check over and say, let's build out our behavioral health services, as an example. It may be, let's put an oncologist, neurologist, or whatever service on Maui.
Which makes sense when you do it, but are you gonna pay for Queens to do it?
Yeah,
That's where-
absolutely.
I think that's where the
Well, today it would make no sense for HPH to do it.
right.
Today.
One
know what
Health
Health
would
it does.
absolutely, that's what you would want to do. That's the whole point. That would be
Senator
the-
Joy, I
think
think
that's
you
where
asked
some
me
of
to look
the-
at the camera at the last meeting and commit that that was our intent, how
Yeah.
to do that. And I looked at the camera and I'll do it again today. That is our intent, this is about allowing all boats to float higher and generating billions of dollars worth of value creation to invest.
I'll believe it when they're not over there, they're over here.
Yep,
Because right
I
now
do want to
they're
hear
over
from
there.
Queens on this too.
yeah, but there is no way for me to make you believe a future state outside of accepting my work and
That's all we got.
and proving it.
Yep, no, we got. No.
That's true of any of us as human beings. It's what we do, not what we say.
But this does kind of feed into the conflict of interest portion that makes this whole thing more unbelievable and more difficult to believe, I should say. I mean, you are saying that by combining, you're gonna try to help your opponent. You're also saying that by combining your interests, which are opposite, will suddenly kind of mesh and come together. It's just hard for us to, but
I haven't bought into the fact, Senator, or the Chair, Mr. Chair, that our interests are in conflict with one another. We've been aligned for the better part of the last decade, moving along this journey together to try to get here.
I will tell you that, I'll just tell you real quickly in answer to that question. In the example I gave that you didn't like, because you didn't like the pit, but in the Highmark Allegheny thing, money from Highmark was directly given to UPMC to invest in them because it was better for the Pennsylvania community. The savings generated on that integrated entity went directly to the other health system.
okay, that's right.
I think there's a lot to unpack there. Maybe if I could address the question about behavioral health care. You know, would we appreciate other health systems and hospitals having behavioral health? I think absolutely. So we look at the number of MH1 patients, behavioral health patients that show up in any emergency department and then get transferred. One, there's a cost to the patient. At a minimum, $600 for that patient to get transferred in an ambulance from one hospital to the next hospital. So there's cost, added cost, unnecessary cost. Then half of those patients go home. And so if you can keep patients in their communities, lowest cost, I think that is the absolute best case. In today's world, if there's a patient that needs to be admitted, that's where our transfer center, takes a look at the evaluation. We agree that that patient needs to be admitted. There's a risk to the patient for self-harm, and then we would admit the patient. But there's clearly an underbedding. It's the reason why we bought Kahi'imohala, because we knew that if 88 behavioral health beds disappeared because Sutter Healthcare was going to close Kahi'imohala, that would be terrible for the state. And the investment that we make in Kahi'imohala is in the tunes of millions of dollars. Our behavioral health investment is 15 million plus, depending on the ebb and flows of whatever's going on in the community. Seems like holidays always peak up because kids don't have places to go, and then they can hide during the school year, and so the census goes down. But if you aggregate that out, there's a huge need for additional behavioral health beds, both pediatric and adults, and on neighbor islands as well, because we do take quite a few patients from neighbor islands over. There's a second comment about why Medicaid. So there's a reason why I would imagine that there's a higher reimbursement of Medicaid going to HPA, just because behavioral health is extremely low reimbursed. We get very underpaid. That's why there's an investment that we make in that every year. Same thing with the homeless cellulitis patient that shows up. They come back, recurringly. It's low cost. The reimbursement is extremely low. We lose money on every one of those types of patients, but we keep our doors open and we take care of them regardless of the care. If you can contract well on NICU, so NICU is really where the Medicaid patients are going. If it is paced very well, then obviously you're going to have quite a few patients that are coming in generating more revenue. We considered getting into the NICU business. Our NICU would have been small, but our labor and delivery, we have half of our OBs delivering between two hospitals, and the mothers say we want to deliver at Queens, and so we went down that road. We were discouraged from trying to build the NICU, so we stopped. We did stop. And I think that as we think about comprehensive care, that's something that we should invest in the future because it protects our attributed population of patients that are at Queens, both those that are affluent with commercial insurance and those that have Medicaid. So I think when you think about the investments that need to be made, really, really important when you consider the types of patients that are going between each place. I think the assurance is that patients won't go back and forth. I think this really, the problem is in the Medicare and the Medicaid patient. The costs, the overutilization, I think the under management of chronic conditions. But the risk, and the reason we're sitting over on this side of the room is because One Health Hawaii doesn't distinguish that we're only going to address Medicare and Medicaid and fix whatever's happening with cost, access, and care. It's the whole bucket of commercial and Medicare and Medicaid. And so having nobody talk about the commercial population and what's going to happen there, and the protections that will stay a competitive free market, that patients can choose where their doctors are and not have a cost differential, that doctors don't have to decide whether they're going to line one way or the other, or they're forced to participate in value-based. And if you do participate in value-based, is it going to be harder for me to be successful if I have or I choose to take care of a sicker population? Those are risks. And so I think when you think about this whole model, there's still very valid reasons why we are concerned and don't believe this is the right thing to do. Many of the things that we've heard in terms of lowering administrative burden, improving care, they can happen without the merger. And when you think about why One Health Hawaii would be interested in supporting behavioral health or physicians on Maui, it's because they're a provider, because they have members that live over there. So it's not a matter of One Health Hawaii. I would say HMSA should be interested today in taking care of their members on Maui or taking care of their members in rural communities. They could and can do it today. So it's not the question about, do you need One Health Hawaii to decide that all of a sudden that's where you should invest your money and resources.
While I have you up here, do you agree with HPH that behavioral health should kind of be centered in Queens, or is there something that you would, if you had the ability to do, that you would like HPH to do to take some of those behavioral health, or does it not make sense? Does it make, are they right that it makes more sense to kind of centralize it at Queens than you would just want them to kind of give you more money to help with that?
I would say that we've done a really good job with the resources that we have. We're still under-resourced when it comes to behavioral health. I think if you're going to be a comprehensive, integrated, vertically integrated system, you should be comprehensive. So I think about Geisinger and the relationship with Kaiser. Geisinger was a comprehensive health system that had a small health plan. It's got skilled nursing facilities, it's got behavioral health, it's got critical access. It's comprehensive. It's a wrapped up box ready to go.
So you want the health, not the money, is what I'm saying.
You need the healthcare. And so you think about the vertically integrated system, HMSA is still going to be completely reliant on Queens and all the other providers in order to provide care to their members. And so when you think about scale, efficiency, it doesn't make sense. You've got a small health system that's trying to be the provider and it's still not going to be complete.
Save that for last.
Respectfully, legislators, since you are legislators and you will be considering Senate Bill 2804, I just want to say when Queens did the wonderful act of taking Kaimohala so that we could make sure the viability was there. When they did the same thing with Wahiawa, that was great too. And 2804 would make those elite. So I just want to make that statement.
Any other questions? Martin?
Yeah, I want to talk about what it would look like if this merger didn't happen. So it's very ironic to me that last year we spent a lot of time talking about prior authorization, and you folks kept telling me that it wasn't a big deal for you, and now we're hearing that there's going to be all these savings, part of the $2 billion if we deal with that problem. But the other side of it that you mentioned, the other place where there's cost savings is deduplication of services. And I imagine not a lot would come from the very top, but from the case management and stuff. But now we're talking about everybody having the same electronic medical records. And we know that we're really pushing to better integrate our data across different service providers already, to do more shared case management and have better historical records. So wouldn't we get, if we continue on that path and push hard on that path, wouldn't we get those same savings anyways?
Go ahead.
And I mean for the whole system. I'm not talking just about between HPH and HMSA, but for the whole system, moving along that more integrated care model with sharing of records.
Yes, we would love it, but that doesn't happen today. I've been the CEO of HMSA since 2019. And from day one, that was my goal. And we even tried to come to the legislature to mandate it because that would be a great thing. And we are in the same place today as when we started in terms of being integrated with data and therefore improving the way we care for people. One place where we've moved along, but not far enough, is with them and our value base, because we share some data so we can solve the questions in our contract, but not all, because we're two separate organizations. So just think about how much more value you could get if you could put everything together, and that's what this is. And it's a model and a stepping stone for us to get that way with everybody else, because we're much farther behind. And just clarifying on the prior auth, we're very serious about resolving that, but that is more about relieving administrative burden and allowing providers to focus on the things that matter most to them, which is caring for the patients. It's less about actual cost savings and more about like, let's get them working at the top of their license and not dealing with a lot of administrative burden.
If I could just add something. And I don't want to sound like a doomsdayist, but the reality of it is if this doesn't happen, we're essentially committing to the relative status quo. And that means sustained access issues, sustained unsustainable rates of increase for the cost of health insurance. I don't know how fast the administrative burdens like prior authorizations can be removed or not, but that in itself is not enough to keep up with the cost of inflation for drugs and supply chain and things of the like. I know you all study the issues on a statewide basis every day throughout the course of your year. I hope that you would believe that the current system is unsustainable. And what we're trying to do is inject meaningful structural change that allows the savings and the value creation to outpace the rate of increase. And that is a challenging task. And it cannot be done in a slow, incremental, around the edges kind of way. Because I think we would all agree, and again, I don't mean to speak on behalf of my colleagues, we go through budget prioritization and cutting around the edges every single year, every single budget cycle, and it's not enough. And my fear is that it begins to have a long-term impact on the health of our community if we don't do something of significance to change the current trajectory.
All right, we've gone a little over time, but I want to thank everyone for being here. I really appreciate HMSA and HPH for showing up and giving us more information about the planned partnership. Thank you to Queens and Castle, HMA for showing up as well, and Kaiser. I don't know if they're still here. Anyway, thank you Kaiser for showing up. We appreciate all the information given. I think I'm still hung up on whether the competing interests of an insurance company and a medical provider are going to be able to exist in the same entity when it comes to the choice between how to use the money, whether to lower premiums or to build a hospital or to increase pay for doctors. I think there's a natural push and pull that these two companies have historically, the two nonprofits have historically, but it heads on that I hope will be resolved with One Health. I mean, I genuinely hope that One Health works out and everything that you've been telling us comes to fruition. But I think that I probably speak for many of the people in the legislature when we say that we're still nervous. We still need to see it happen, and until it actually happens, I think we're all going to be a little doubtful.
Doesn't Kaiser demonstrate that, doesn't it, Mr. Chair?
Yeah, Kaiser still negotiates. Anyway, totally different story. But I also do want to say that the commercial side also bothers me a little. I mean, I am concerned, and you've heard the questions of both committees and other chairs from other committees too. I think we're all concerned that on the commercial side, there is going to be incentives to essentially be cherry picking to siphon off healthy patients, intentionally or not, to the One Health system, and that may hurt the Hawaii healthcare system as a whole. So that being said, I mean, we do appreciate you folks being here. I think we had some good information that's now public out there now, and I hope the conversation can still continue, not only with us and you, but with you guys and each other as well.
Sure. Thank you very much.
All right, we're adjourned.